Okay, I'm 45, so we'll kick off. Welcome everybody to our third in the series of webinars around niche to normality, genomics for nurses, midwives and healthcare professionals. We have chosen today specifically, it's a very special day. It's the 29th of February, leap year, that doesn't come around very often, but it's also a day that's been chosen to be Rare Disease Day. And this is a movement that was started in 2008 to raise the profile of people living with rare diseases. Today we're focusing in our webinar on the patient and family experience of genomic healthcare. And for individuals living with a rare diagnosis or with a rare disease without a diagnosis, genomic medicine is having a great impact, and we're going to explore that today. So thank you very much for joining us. Can we have the next slide, please? Great. So just a bit of housekeeping to begin with. Phil's controlling the slides today. That's why she's laughing. So our housekeeping is, please note that we are recording, and we will share the recording with everybody who's registered. We're obviously aware a lot of clinical people plan to come and often can't make it, or they can only make it for part of the webinar. So we will be sharing the recording, and it will be uploaded to our website and to YouTube. Can we ask that you ensure that you're muted during presentations? Feel free to put any chat, discussion, questions, anything you'd like to just give to the group into the chat, and we will read those out, and you will have an opportunity to ask questions and contribute at the end of each talk. And we would really like this to be an interactive session, so please feel free to put your hand up. Next slide, please. So just an introductory slide, just to let you know that we are the Central and South Genomic Medicine Service Alliance Nursing and Midwifery team. And if maybe we start with Charlotte, if anybody wants to just say hello.
Pick on me when I'm trying not to be on a team. Hi, I'm Charlotte Hitchcock. I'm the Associate Director of Nursing and Midwifery for the Central and South Genomic Medicine Service. And it's really great that you're all here. Thank you.
Phil, we'll go down the list.
Hi, I'm Phil Costello. I'm one of the lead nurses with the Central and South GMSA, and I'm based down in Southampton. And it is really great to have all of you join us today on this, as Donna said, quite a special day. So thank you.
And Karen.
Hello, thank you, Donna. Yeah, I'm Karen Creed, and I'm lead midwife at Central and South GMSA. Thank you, everyone, for attending today.
And I'm Donna, and I'm the lead nurse that's based at University Hospitals in Birmingham. Next slide, please. So this is our agenda for today, which I'm sure you've seen. So we're just doing a brief introduction, and then we've got some fantastic speakers, kicking off with Dr. Valine Lesperance, who's going to be talking to us about addressing inequalities in precision medicine, and she's from the NHS Race and Health Observatory, and she's going to give us a sneak peek of a publication that will be coming out in the spring and some of the information that they've been pulling together. At 10:40 we have Dr. Porrick Dixon, who is going to be talking to us about health insurance and genomics, which is obviously of great concern to many patients and individuals, followed by Professor Annika Lucassen, who will be talking about how we use all this molecular genetic information, this data that we're collecting, in a useful way, how that's translated into a useful way for patients. We will have a short break. There's a little rare diseases video in that break. It's only a minute, but we'd like you to take the time before you run for your cup of tea to just listen to that. And then afterwards, we're really privileged to have two of our representatives from our patient and public panel, Sadia and Joe, who are going to talk about their family experience of rare disease and genomic medicine. And then hopefully we'll have some time for any follow-up questions at the end. So next slide, please. So as you know, we're always asking you to fill in surveys. They're very small surveys. There's one at the beginning, which hopefully you've already got, and there's one right at the end, which is feedback after the webinar. And we're checking really that we're hitting the right spot and we're telling you what you want to hear. And also getting an idea of who is listening in, because it is very varied. These are introductory sessions, and we're getting quite a wide variety of people coming along. So one of our aims is to introduce the genomic education programme and signpost towards various genomic education that is in existence, a lot fueled by NHS. And from our previous feedback from the other webinars, this is the last webinar, we can see that sort of about a third of people that came. So I suppose we're talking to people who have a knowledge of genomics, they're seeking it out. And about a third of those had accessed the genomic education programme prior to the webinar. And in the follow-up feedback, that jumped to over 80% had gone to have a look, which is really good. And we do have a slide later, I think it's towards the end, which will give you some more information if that's something you're interested in looking at. Next slide, please. This is what you're telling us you're looking at, and there's a wide variety of genomic information out there, specifically in the genomic education programme. We can see that people have been looking at the bite size in the clinic. Mini little webinars, some of them are only 10 minutes, or there's information about what if you're in the clinic and you've got a patient coming in to talk to you and you suddenly think, is there something I should know? Is that, you know, you just wanted to have a double check before you see that patient. And then there's a knowledge hub, which has got a lot more in-depth information. Genomics 101, I think, is on there, and also right the way up to a master's in genomics. Next slide, please. And this has got a load of stuff on it, but basically it's just letting us know that from the last webinar, I think it was about 60% of people felt that the information that was shared would influence their clinical practice. That just tells us that we're hopefully hitting the right spots. The people that have filled in those questionnaires, interestingly, a lot of them represent the research community, but we've got individuals who are nurses, midwives, radiographers, we've got practitioners, nurse associates, people from cardiac backgrounds. So it's quite a variety. And the topics that you're asking us to address, again, are quite varied. Education, mental health, cardiac conditions, counselling, testing, and the couple that we've really picked up and we're moving with today and addressing today is focusing on insurance and the patient story. So I think that's the end of you'll be glad to know, my little feedback. So just an encouragement for you to fill in our surveys, because we are listening and we are trying to make these webinars specific for what people want to learn about. So how are we doing with time? I think our first speaker's on at 10 o'clock. Is that correct? So let's just have a little look and see who's here. Okay, so our first speaker isn't here as yet, so we will just...
Yes, I am here.
Oh, hello. Hi, Belen. Thank you for coming.
Yes. Thank you. I'm happy to start early if you like, or wait until 10, let me know.
Well, I think Karen was just going to do a brief introduction for you and then crack on, if that's okay. Thank you.
Lovely. Can I just check, are you, we've got your slides up. Are you going to control your own slides?
Yes, I have my slides. I'll share my screen if that's okay.
That's great. Thank you. So I'm really pleased to introduce you today, Belen. So this is Dr. Belen Lesperance, who is a senior clinical advisor and genomics lead to the NHS Race and Health Observatory. She's also an academic GP based in South London. So really interested to hear about your talk today. So we'll hand over to you. Thank you.
Great. Are you able to see the slides all right?
Yes, we can. Thank you. Perfect.
Excellent. Okay, so essentially I am from the NHS Race and Health Observatory. So I'll start by telling you a little bit about what we do, and then we'll go into our precision medicine and genomics work. This is a very interesting quote. Essentially, ethnic inequalities in health outcomes are evident at every stage throughout the life course, from birth until death. And essentially, this was a quote taken from our seminal report looking at ethnic inequalities in healthcare, a rapid evidence review. And this is one of our first publications, essentially. And here we see a stark look at ethnic health inequalities in the UK. For example, Black women are 4 times more likely than white women to die in pregnancy or in childbirth in the UK. In Britain, South Asians have a 40% higher death rate from coronary heart disease compared to the general population. And across the country, fewer than 5% of blood donors are from Black and minority ethnic communities. So that just gives a sense of essentially the ethnic health inequalities we're facing as clinicians working within the NHS. So the Race and Health Observatory was really set up to essentially provide the evidence about racial and ethnic health inequalities, not only from commissioning original research, but also to fill the gaps and synthesizing and mobilizing existing evidence. We're also tasked with influencing, so we use the evidence we commission to influence leaders through practical recommendations and policy practice. And we implement on the basis of our recommendations and in response to the needs of the communities in which we work with. We work to support and to support the implementation of new policies and practices from the grassroots level. Our work streams essentially are across 5 major areas: improving health and care, empowering vulnerable communities, innovating for all, creating equitable environments, and collaborating globally. In terms of innovating for all, the genomics and precision medicine work stream sits within this category. So our impact is judged by our insight and evidence, driving policy change, influencing leadership, definitely engaging the public, which is at the heart of what we do, and creating practical tools that can be used within the NHS to drive forward change. So I am tasked with overseeing the genetics, genomics, and precision medicine work stream. Essentially, precision medicine, as you know, has the potential to transform health and medical care through the provision of the right drug at the right dose to the right patient. It rejects the notion that one size fits all and strives to understand human genetic variation in populations and individuals and how these patterns influence disease, pathology, and treatment to develop tailored therapies which are most efficient. So essentially, this work was commissioned by the RHO and undertaken by teams at the University of Nottingham and Nottingham Trent University as well. So I'm going to present essentially findings of this large review, which took about 18 months to undertake. And I know some of you on this call also kindly gave up your time to participate in some of the focus groups and interviews, and I thank you for doing that. So the review essentially consisted of 5 main objectives: to understand the current priorities in achieving ethnic equity in precision medicine by reviewing policy and guidance documents, to identify ethnic inequalities in recruitment for biomedical research and in patients' access to precision medicine through academic evidence synthesis, to identify educational and service needs for better implementation by assessing public and professional stakeholders like yourself and practice in promoting access to precision medicine services, and also trying to understand the likely barriers and facilitators to accessing genetic medicine services. We also sought to investigate equity of access in the uptake of genomics testing by exploring current practices in data recording of protected characteristics such as ethnicity, and to evaluate the key barriers and facilitators in this data monitoring. And then finally, to identify information, education, and service needs for promoting equitable access among individuals from diverse ethnic backgrounds through exploring their knowledge, attitudes, and engagement with precision medicine services and also research. So first of all, the policy guidance and document review. Essentially, sampling consisted of documents focused on organizations such as think tanks, government boards, that really focused on precision medicine and genomics related healthcare. Yep. And also those providing advocacy or priority or agenda setting within this field. Only documents published within the last 5 years from 2017 were included in this synthesis. Essentially, 70 documents were published in the last 5 years, were included in this review. And these came from the government, NHS England, Public Health England, Public Health Genomics Foundation, Genomics England, and Public Policy Projects and the King's Fund. These were extracted and analysed using an inductive thematic analysis. So essentially, the results from this document review highlighted that there's an underrepresentation of ethnic minorities in genomic data sets. These data limitations are far-reaching, and the consequence for ethnic groups regarding the understanding of genetic variation and development of optimal genetic medicine services. Considering that precision medicine research, a lot of the work currently being done on advanced analytic techniques such as risk prediction and development of polygenic risk scores, it then is limited due to the lack of representation of those from ethnic minority populations. Therefore, the predictive utility of such tests is actually reduced. Yeah. There has been limited efforts in order to involve diverse communities and individuals in public engagement to inform genomic decisions, initiatives and action plans. And what's been done has actually been a piecemeal approach. Yep. Details of how this work is happening on the ground is rarely acknowledged. So what we actually need is more of a concerted effort to understand the needs of different communities. There's no one size fit all, essentially. And to engage with them and understand concepts associated with genomics and precision medicine and what that actually means to those communities. And these concepts are not always well understood. So therefore, time, effort, resources are essential to facilitate the education that's required. Okay. We also found that diversity within the healthcare workforce was advocated in these documents, which is considered key in addressing historical barriers to accessing healthcare. But on the ground, this actually wasn't done. Yeah. So there was still lots of evidence of mistrust and suspicion amongst ethnic minority communities. So therefore, training of healthcare staff to foster cultural awareness and understanding and embedding diversity within clinical care guidelines was also addressed, but more positive steps needs to be initiated to carry this forward. In terms of the systematic review, the aim was to explore ethnic inequalities in precision medicine, focusing on recruitment biases in biomedical research and genomics medicine and patients' access to precision medicine. We looked at 4 major databases. Over 10,000 titles were identified from unpublished sources and also the grey literature as well. Of those, 143 met the inclusion criteria. 137 of these focused on more data-related studies, where 6 focus on qualitative. So here are some of the outputs from that review. What we found is that most of the studies provided a basic descriptive information about ethnic minorities. So essentially tend to group groups together. So Asian together, Black together, as opposed to sort of separating these out and looking at the finer details. as most of the UK studies are reliant on UK Biobank, this information was essentially identical across several papers. And in terms of the socioeconomic profile of ethnic minorities in the database, the actual genetic analysis of minority groups appeared really rudimentary, and the findings were rarely interpreted in the results or in the discussion sections. So essentially what you found was that there was some statements towards inclusion of ethnic minorities, but actually looking at particular variants across those groups weren't actually done in these studies. So although ethnic minority groups were incorporated into the analysis, this was simply as a covariate, rather than identifying any clinically meaningful differences between ethnic groups. So essentially, this then provides limited recognition of what these variants may hold for different communities. In the qualitative studies, ethnic minority groups had concerns about providing their samples for biobanking research. What would happen to this data? Will the government have access to it? Will police organizations, for example, have access to it? Where will it go? There was a reluctance to participate in genetic studies. And this was rooted in negative historical experiences with researchers. And there are also questions about how communities themselves would actually benefit from such research. As a researcher myself, I know that we sometimes go into communities, we collect information, collect data, but we're not always the best in feeding that information back and understanding how that data and information will be used in future. So I think that's something that we definitely need to work on, and there is strives in that direction. In the stakeholder interviews, we consulted clinicians, researchers, community engagement representatives, and policymakers. We also sought guidance from yourselves, from the Genomic Medicine Service Alliance representatives, and also public stakeholders from different ethnic minority groups. We explored the knowledge, attitudes, understanding, and practice in promoting access to biomedical research, genomics, medicine services for ethnic minorities. And we took all of this data and used an inductive approach to analyze this qualitative data. So the data was collected via semi-structured interviews and focus groups as well. And there were also informal sessions as well. What we found is that professional stakeholders with working experience in clinical settings highlighted how healthcare professionals and leaders biases may actually affect how services are accessed and how testing is undertaken. Professional and public stakeholders discussed how having a genetic condition in some cultures may impact the individual as well as their families. We discussed the implementations of testing outcomes for patients and their families, and the result of a finding how it may impact certain groups, and how the result itself may bring about stigma and affect the patient's social standing within their community, and affecting prospects for members of their families, for example, marriage. So these were key things that came up in a lot of our community engagement groups. We also found that professional stakeholders discussed how parents may experience shame or guilt if their child is diagnosed with a genetic condition, and how often in minority groups these feelings of shame and guilt are largely burdened on the mother. So these are things within the clinical setting we need to sort of address head on and discuss quite openly with patients. Professional stakeholders also pondered possible ramifications of testing outcomes for people from already marginalized and minoritized groups, may further sort of marginalize them and their families within their own communities, leading to reluctance in accessing genomics services and undergoing testing. It was highlighted that definitely more training is needed for healthcare professionals outside the genomics medicine service. So for example, when a GP refers a patient, the GP has that sort of wider discussion with them so they understand, I guess, have a baseline understanding of what going into the service is going to be like. And they could do some background reading before their clinic appointment. So again, making the patient feel at ease and have a better understanding before they get to your service, which could then help to alleviate some of their fears, essentially. Yeah. We also need to address biases within stereotyping by healthcare professionals as well. And these can be sometimes conscious or unconscious, where we have a view of a certain ethnic minority group, and that then influences how we approach discussing testing and certain clinical implementation. There were also challenges with ethnicity data recording. So some of that stemmed from clinicians not asking patients what their ethnicity is in some instances, as it's not mandatory, it's therefore not asked. And in instances where we're still collecting information on paper, where it is collected, again, because it's not necessarily mandatory, because of pressures we all face, it may not be seen as important to enter. But also, we have to realize if we're asking patients about their ethnicity, we need to have an understanding within ourselves as to why we're asking the question and what the impact of that will be. Yeah, because those who may be undergoing testing in the lab, they may feel that that's valuable for certain questions. So it's good to feed that back to the patient. So in terms of our public stakeholders, we sought discussions with people from Black African, Black Caribbean, Indian, Pakistani, Bangladesh, Arab, and mixed ethnicity groups, essentially. What we found was that, and it's not surprising, was that there was a variable knowledge and awareness of the links between genes and our health in terms such as genomics and precision medicine. Yeah. Stakeholders also queried the knowledge and awareness of genomics and precision medicine amongst other healthcare professionals outside of the field. There were barriers in terms of accessing translators and challenges around accessing translators and the accuracy of the translators. I know we're dealing with quite complicated subject matter, and therefore it's important that the translators that are used within the genomics medicine service are fully equipped to translate these questions, queries, and information in a cohesive way, but most importantly, one that is fully understandable to the patient. Yeah. There is the role of community and faith leaders in sharing information. There was also suggested that a multi-generational approach to improving genetic and health literacy amongst communities. So essentially having information fed to some of the younger generation, and they then explain that to elders that live within the home or within the communities. There was the need for tailored strategies for different communities. You know, it's not a one-size-fits-all approach. And the messaging can't just be going in, saying something once. It has to be sustained. Yeah. Community engagement, as we know, is key in improving equity of access in terms of genomic services, but also in terms of participation in research. Mistrust, fear, suspicion of healthcare professionals, the health system and research as a whole is definitely still there. And we also need to think about the role of lived experience for people who have been through the service, had genetic testing where it has brought about change in their and their families' lives. We need to seek out these people within the community and have them essentially share their story and share their voice with those in the community to actually say, well, this was very helpful. This was a positive experience, and this is why, we shouldn't necessarily be fearful or suspicious of healthcare professionals looking into areas of genetics and genomics. And we ourselves need to acknowledge and understand the reasons for this mistrust. And once we understand those reasons, then of course we can then use those to improve engagement with services, testing, and research. So overall, the recommendations were across 4 main areas. We have a need to build community engagement effectively by mainstreaming and embedding genomics and precision medicine within the NHS. We needed to try targeted engagement approaches. Genomics England, their community ambassador program, and Genetics in the Community develop tailored communication channels appropriate for different communities, and really still work on building trust with local communities. In terms of policy and practice, interpreters who are qualified and able to communicate complex medical terminology. And then, of course, data is definitely an issue. We need to work hard to ensure that we have this data on persons accessing the service so we know where the gaps are and can focus on communities where we need to. And there are people doing very good work across the country, so there's no need to sort of reinvent the wheel. We need to seek out those that are doing good work and evaluate those projects so that there's a shared learning. And obviously better representation of ethnic minority groups within the workforce based on the communities that are being served. In terms of research, we need more diverse databases. Ethnicity coding needs to be inclusive and consistent across the electronic patient health record system. Lived and historical experiences about ethical research practices really need to be acknowledged. And a critique of the incorporation of information on ethnic minority groups in established databases also need to be done. And it needs to also be official guidance or policy for research procedures in terms of making studies more accessible for minority groups, but also changes in the way in which we allow publications to occur. So not necessarily just essentially doing basic sort of rudimentary analyses when it comes to ethnic minority groups, but also doing more detailed analysis that can be useful, even if they show the results that the researcher may not necessarily want. And there's still work to be done in terms of workforce training, in terms of genomic education across those outside the field. And thinking about genetic diversity and cultural awareness. Yeah. And also general training for non-health workers involved in decision-making, chaplains, for example. And training around data collection for ethnicity and protected characteristics. So overall, those were the key recommendations from our precision medicine and genomics review. In terms of other ongoing work, we're currently undertaking a review into ethnic health inequalities in genetic testing and diagnosis of familial hypercholesteremia. So that's really focused in primary care and looking at how GPs identify patients who may be at risk of familial hypercholesteremia and their referral patterns essentially into the GMSA. We're also looking at identification of novel variants in the DPD gene, which cover major ancestry populations being served by the NHS. And what we were able to find so far was, this is being done by Professor Surmanir Mohammed out of the University of Liverpool, he identified a variant normally found in Black African and Black Caribbean populations, which isn't included currently in the database. So we're pushing for that to be included. And then our final upcoming work is specifically focusing on identification and assessment of ethnic health inequalities within the genomic medicine service. That's working in partnership with the GMSA to bring about change. So in terms of that project, that is going to go live. Well, the tender is going to go live in about 2 weeks' time. It's currently still with NHS England getting their approvals, because this will be in collaboration with NHS England. And what we're hoping to do is identify current access, utilization, and diagnostic performance of genetic medicine services by ethnic minority groups. And for that, we are going to focus on key disease areas, for example, Lynch syndrome, prostate cancer, and colorectal cancer. However, this will be in partnership with certain GMSAs who come forward and want to sort of work in partnership with us. And this may change because regionally there may be priorities that they may want to focus on. So we also want to understand the areas of potential racial and ethnic biases along the patient pathways within selected GMSA geographies. So like I said, we will probably collaborate with probably 2 GMSAs that put their name forward and want to work together with the Race and Health Observatory to get this work undertaken. We'll review current initiatives and quality improvement projects being undertaken throughout the NHS, addressing health inequalities, and really looking at if these initiatives can be scaled and applied to other regions. We also want to develop a common framework by which other GMSAs and the wider NHS GMS supporting services can review potential biases of their service as a mechanism for quality improvement. And then, of course, we want to develop and implement impactful case study solutions to improve the delivery of genomic medicine across the NHS GMS, particularly for ethnic minorities. These are just recent highlights from the Race and Health Observatory in terms of the work we've done with learning disability, neonatal assessment, and caring for the workforce post-COVID. So that's it from me. Those are my contact details if you want to get in touch and discuss any of this further. So I will stop sharing my screen, and I'm more than happy to take any questions.
Brilliant. Thank you so much, Feline. That was excellent. It's a huge subject, isn't it? And yes. I found those statistics that you shared really confronting. I think we're sort of aware that there are issues, but I think when you see like them laid out like that, that's very confronting. And also that gap, isn't there, in pulling in the data and the gap in research to be able to. So we're throwing it open. If people have got questions, please feel free to put your hands up. There's a couple of things in the chat that I'll just read out to you. There's a note about the differences in risk for certain diseases. For instance, I can't see the name, sorry, but somebody from a Southeast Asian community who's saying that they obviously have an increased risk of type 2 diabetes. And then there's a question from Lucille around individuals of African descent who living in places that have less sunlight can have a 15 to 20 times higher risk of vitamin D deficiency, and if there was any plans in the UK to address this.
Well,
don't know if that's anything you know anything about.
No, unfortunately, that isn't anything I know about. But I guess it's something we can take back to our academic reference group and see if there's any interest in undertaking work in that area.
Brilliant. We've got somebody's hand up. Who is that? Charlotte.
That's me. Verlene, hello. Thank you so much for talking. Really appreciate it. And as ever, I always find you fascinating to talk to, and it always raises questions for debate. One of the things that you'd said was that often with genetic conditions and any problems for a child, in some cultures, the problem can be perceived as coming from the mother.
Mm.
So if that is the case, and we want to engage with stakeholders, how do we get around the issue that potentially the mother is not going to be available, or women may not be available to talk on their own, partly because of language barriers, and partly because I've encountered it where I've had quite aggressive behaviours from a husband who is just saying, yes, she won't do that. Yes, she won't. She's not going to do that. And a translator desperately trying to get them out of the room so that he could actually talk to the wife. How do we, as a GMS, wanting to engage with communities, attempt to get around those kind of issues where you can almost feel like you're hitting your head on a brick wall, not because the woman doesn't want to talk to you, but because of cultural barriers to allowing us?
Yeah, that's a very good point. And as a GP, I sometimes experience that myself. And I think for us at the RH, I think this is where the community leaders become important and community champions become important. And really, you take these sort of really difficult, almost uncomfortable questions and situations, and you take it to the community leaders and ask them for their input on how to bring this forward. So I know we're talking about individual cases where the patient's in the room, but I think there's actually taking a step back and engaging more with the communities with these more trickier things.
Yeah, I mean, that's definitely what we're looking to do at the moment, and we are beginning to actually have those opportunities. One of the other things, sorry, if anyone wants to interrupt me and put your hand up, please do, because this is just my pet subject about this at the moment. You mentioned the unconscious bias that healthcare professionals may have, as well as conscious bias. What about the reverse? The stereotyping that any person, any patient coming into healthcare might have about who is treating them?
Yeah, I think it works both ways, and some of that in terms of what the patient is sort of feeling, it probably is more fear and suspicion, and I guess a feeling that that person who may be of a different ethnicity, different cultural group, may not have an understanding of what I am going through. So that's where I think the building of trust is important. And I think the more we have cultural awareness of different groups, there are different things you can say or do within that consultation that allows that patient to understand that you're sort of on their side, and you understand, you have, not completely, but you have some understanding of what they're experiencing.
Okay, that's brilliant. Thank you so much.
I think it's a very, very interesting area, and I think like I said, the tender that's going to go out in a few weeks, you know, if Central and South would be interested, I do think that that specific piece about engaging, and where you may have sort of a difference in terms of what the mother may experience compared to the father, I think is very interesting, and how you sort of translate that, I think is very interesting, essentially. Yeah.
I don't need to tell you we will be interested, but moving forward. Phil, I think.
Phil, you've got your hand up.
Hello, thank you so much. Everything you said just resonates so much. And as you know, we are doing lots of work, starting to look into the ethnicity, thinking about inequity within genomics. I think one of my main questions is, we have lots of mandatory training as healthcare professionals, and so when we're thinking about unconscious bias or stereotyping, how do we get around that? How do we try to change the views of healthcare professionals when we're thinking about having those conversations with race or including genomics, when a lot of people think, well, I have had that training, I'm doing it. You know, what strategies do you think we need to put in place? Because we can't keep on having this conversation. This is not a new conversation. We've been talking about this for many years, and things are not changing. And if it wasn't for COVID, would we still be having this conversation, or would it just still be the norm? You know, so it would just be interesting to get your views on that.
Yeah, thanks, Beth. I think that's a really good question. I think we all have mandatory training and we all feel it's all a bit tedious, yes? And most of the time it's actually done online in your own time and you just really just want to get through it. I think these conversations are so important and so sensitive. I do think that they have to be done in an open environment. You can do these online virtually, but I do think that it's probably worth getting people together and actually having specific workshops where people feel safe and people feel they're in a trusted environment where you can be open and you can talk about this. And I think it does take courage for some people to essentially talk about their own experience and their own feelings. And I think once you start the conversation in an open group, then people can understand a little bit better. It's very different to just doing a online training where you're just going through the slides. Okay, cultural competency is this, cultural awareness is this. I think really it's about understanding and having people talk about their own lived experiences as well. Yeah,
totally agree. Thank you so much. I think there's a couple of questions in the chat we probably should go to.
Yeah. You want to read those out, Phil? Can you see them in your view?
Donna, go ahead.
Okay. I think there's a comment there from Amanda Skinner just saying that this is obviously talking about mothers addressed in maternity care and A&E, where nurses and midwives always try to have a private conversation with a woman. So there is an awareness, obviously, in the workforce that there can be issues. And then we have a question, I think, from Mary. You've mentioned engaging community leaders would have an impact in these genomic conversations. I just wonder what our GMSA is doing at the moment to engage with these community leaders. Have we made any breakthroughs? So I might pop that back to Phil, because that's your, or Charlotte, that's your sort of area, isn't it, when we're talking about GMSA and working with the community?
So Phil's currently leading on EDI, but I'll butt in as and when, because you know me, Phil. But yeah. Do you want to start, Phil, with some of the work that you've been doing?
I was just going to say, we've put together a strategy for the Central and South GMSA, and we're now starting to look at the actions and what activities we're going to be putting in place to engage with the community leaders. And one of the first things is thinking about our patient and public panels and how we can increase representation from our region. It's a huge region, and it's a very varied demographic across the region. So we have started looking into it. We are right at the beginning of it, and also we've also recently made contact with some other groups that are doing a lot of work within the communities to think about how we can start engaging and using those different groups as well to support, where we can either support or they can support us in going out to the communities to talk about genomics and raising awareness and thinking about why are we asking the questions. If you're asked this question, why are we asking the question? What the relevance of the question to potentially the results we're going to get back. But going further than that as well, when we're thinking about research and getting more data in, it's also about making sure that people are involved right from the beginning, that if we're going out to the communities, we are engaging with everybody and getting input right from the start. So we don't have what we have now in terms of all this wonderful genomic technology advancements without research. And if that's going to benefit everybody, then we need to make sure we're getting that information out to everybody. So there is work. We've started looking at our plans and our actions and our activities on how we start going out to the communities, and I have made contact with some groups already.
So just to follow on from that as well, what we're doing within the West Midlands, there is a cancer network, which I appreciate that's just cancers. However, many of the people on that come from Health Watch. They come from some minority groups who want to have a say in different things. We have Health Watcher present. We've got people from Yemeni community. And also we're keen to reach out and talk to more people as well through multi-faith leaders. So we're doing that as well, but we're also talking to people within communities about how do you actually want us to reach out to you? A lot of people are doing screening in the community and have taken out the big bus. That's fine for some people, but not everyone wants to have it seen that they're getting on a big bus within their community. So we're also looking at what people want and need. It isn't about us, it's actually about what can we do, and we can't determine that. We need to ask the people who are out there. So we have got talks ongoing with different community groups. We want to have discussions which are very open towards them talking to us and asking us and telling us what their fears might be. So we would almost be looking at a kind of a round table whereby we're the ones who have to answer the questions. We're the ones who have to be able to provide answers, securities, but also it's about us being able to say to people, we're not telling you you have to do this. All we want is an understanding of why you may not want to do that. And if that is something that we can provide you more information about that makes you think, actually, this is a good thing, that's great. If, however, you can say, yes, I can see why it's a good thing. But for us in our community, that is never going to be something we would consider. That's great. We then have a rationale. So it's about things like that. But I also think we need to use staff. You know, healthcare is not simply white middle class Anglo-Saxon individuals. It's everybody from all sorts of different communities, different countries, different experiences. So we need to also engage with our staff far more.
Thanks, Charlotte. Thanks, Phil. There's a couple of comments I'm just going to bring out from the chat. One from Vinay. I think when discussing awareness of and access to genomics and precision medicine with underserved communities, one issue that comes up quite quickly is that they struggle to access basic healthcare and GP services. How can we convince them to engage and that their voice will be heard when genomics looks simply too distant and there are more pressing needs? And I think the comment may be below. I'll read that as well because that's sort of relevant. Would a champion role, this is from Kelly, would a champion role be appropriate in individual departments to address any issues that happen in their own areas, raise awareness to their own teams, and then extending this information out more widely? We already have dementia champions, wellbeing, etc. A cultural competence champion, good idea, would be a brilliant addition to be able to tailor a service to the local needs. That is also specific to the medical need being treated. Well, they're coming in thick and fast now. So, I mean, maybe go back to Vinay's question there around how we're going to increase that engagement from underserved communities when they're struggling to access basic healthcare. So, any thoughts on that?
Yeah, I guess, you know, that's a question regarding sort of the wider NHS and access, which we know is a struggle for everyone, but particularly those from underserved communities. What I will say is that the Genomics Medicine Service is a relatively new service. Yeah, so this is, you know, newer than all the other established services within the NHS. So for me, it's quite startling to know that even within this new service where we have a new way of thinking, we have the same issues that we have in maternity services in mental health. But really we're pushing this precision medicine risk assessment tools out And a lot of that is actually being focused in primary care. So we can't necessarily push this agenda unless we bring all communities along. So although, yes, there are struggles within the NHS as a whole, and particularly within primary care, we have to still ensure that we bring all the communities along with us. So we end up in a situation where we only have data that's usable from people of white European ancestry being built into these precision medicine tools, essentially. So I do think that things like community champions going out in the community and having patients understand the role of genomics and precision medicine is still very important, because that's the agenda that's currently being pushed. And we can't just say, well, we're not going to focus on these communities because it's so distant. The point is that it's moving, and we have to ensure that communities are moving along with it.
That's great. Thank you, Valine. There's another couple of comments, and then we probably need to move to our next speaker. But there's just a mention here from Mari about genomic practitioners or associates who have come from a certain backgrounds and speak a certain language, which is really useful about that translation that you mentioned in your talk. And then also we've got mention of Born in Bradford, a podcast on the G word about researchers working together with the community leaders, which has been really successful, breaking down barriers. So I think lots of conversation. We could probably go on all morning. Continue putting anything you want to in the chat, because we can pass them on even if we haven't got time to discuss them now. But thank you so much, Valine. That was brilliant. Thank you for coming in, making the time. And we shall move on to our next speaker. Thank you. So let's just check. Karen is going to,
Porrick, oh, you're here, lovely. Hi, welcome. So next up we've got Dr. Porrick Dixon, who is a senior researcher in health economics at University of Oxford. So Porrick's going to talk to us about insurance in genomics and how this area is evolving. So I'll hand over to you, Porrick. Do you want to share your slides, or?
Yeah, I'll share them. Thank you.
Perfect. Thank you very much.
Yeah, thank you for having me. Just one sec. So hopefully you can all see that, and I'm assuming someone will shout at me. Thank you. Thank you very much, Karen, and good morning, everyone. I'm very happy to have this opportunity to speak to you about the future of insurance in genomics. I think it's a very apt time to be having this kind of conversation. I think it's an area where we're going to see some fairly significant changes in the UK in the coming years. I think the types of conversations that will be had with patients will become more frequent and potentially more complex for the reasons I'll set out in this talk. And before I get into some of the detail, I think it's worth just pausing and thinking about what is insurance, why do we value it, why should we care if it becomes more expensive or less accessible. So the basic idea of insurance, which most of us will be familiar with, it's the idea of something that protects us against losses that are unpredictable. They're associated with unpredictable events. So some events are certain, such as death, but the timing is usually unpredictable. Some events are certain in a community or at a population level, so we know a certain proportion of people will get unwell over the course of a year, but we generally can never identify in advance which specific individual will succumb to ill health and when. So insurance is simply about pooling risk with others in a population, and within a risk pool, so that's a community of individuals who are contributing money, the majority of people who don't need to make a claim because they haven't experienced ill health or some event that they're insuring against, their contributions meet the cost of the minority of people who need to make a claim. And in the UK, over the course of the 20th century, there's some, not very much, it wasn't especially feasible to use genetic information in insurance, but by the late 90s, given the increase in the use of diagnostic tests, diagnostic genetic tests, there was a concern that there could be discrimination by insurers on the basis of people's genetic profile. And that led to the creation of a voluntary code between the ABI, which is the Association of British Insurers, which represents most insurance companies in the UK, and the UK government. And this code is a voluntary agreement, so it doesn't have the force of law. And it's been in place ever since the late 90s. It's changed a little bit over time. The most recent version is from October 2018. The idea is it's reviewed every 3 years. Because of the pandemic, this one was last updated in December 2022. And the code refers to 2 types of genetic tests. The first is what it calls diagnostic tests. So those are genetic tests that confirm or rule out a diagnosis. And the second type are referred to as predictive tests. So these are tests which assess future risk in individuals who don't have symptoms today. So diagnostic is helping you make a decision. Predictive is only defined in the code in relation to people who are asymptomatic. And there are 2 core principles underlying the code. The first is that insurers should never require or pressure applicants to take either type of test. However, applicants for an insurance policy could voluntarily disclose some of this information. Even then, there's another restriction in relation to predictive tests, and that is a predictive test can be considered only if it's specifically named in the code and it's for an amount of money that exceeds a limit that is defined in the code. And in practice, just one test meets these 2 criteria, and that's life insurance cover worth over £500,000 for Huntington's disease. Otherwise, these predictive tests simply can't be used. And we feel there are 3 emerging challenges to the code, and I think this is going to be an important source of how conversations with patients might change going into the future in the near and medium term. The first is whether this distinction in the code between diagnostic and predictive tests is actually meaningful and useful. Then there's similar issues in relation to greater use of pharmacogenetic testing in prescribing. And then finally, academics and in the private sector are getting a little bit more sophisticated in predicting future health outcomes. And some of these outcomes include things that are very interesting to insurance companies, such as lifespan, such as healthcare costs, such as the rates of hospital admission, all of which could in principle be used to price insurance, but that would of course give rise to concerns as to whether that would be fair, and I'll touch on that. So starting with this blurring of the distinction. So if you recall that distinction, diagnostic is helping you make a diagnosis. Predictive is about assessing future disease risk in people who don't have any symptoms. But the code doesn't actually define how predictive a test should be. So you can imagine someone who doesn't have symptoms of Huntington's disease, but is carrying the genotype. That is a very highly predictive test. In other cases, for particular, for example, a cardiac arrhythmia, people are often walking around with these variants, will never express the related phenotype. But is it right that that test is or isn't disclosed to an insurance company because there's a potentially very small risk that that phenotype could be expressed in the future? And of course, often the predictive value of knowing a specific variant is very low if there isn't a positive family history and the phenotype hasn't been expressed to date. So again, how would an insurance company use that information, and is it ever actually going to be useful? If you do lots of testing, you find an incidental finding of some unusual variant, is that predictive, or is it simply something that never needs to be thought about again? And of course, with this huge explosion in the volume of genetic testing, it's very increasingly difficult actually to identify which of the many variants that may emerge from a test will actually impact health. And then if you think in a slightly different context about polygenic risk, which something like our Future Health will be calculating for up to 5 million people if they hit their target, So if it so happens that I'm in the top 1% of polygenic risk for, say, heart disease, is that a predictive test? Even if most people in the top 1% of risks of polygenic risk for heart disease won't develop the condition because it's influenced by other factors such as how much I smoke and exercise. So that's that's an area of challenge where we expect the code maybe to evolve a little bit. And these issues also arise in a more specific way in the context of pharmacogenetics. So as we know, part of the difference in the effectiveness and safety of medicines between people is due to genetic variation. And from an insurance perspective, if you know that an individual is less likely to respond to future medications, say they can't convert clopidogrel into its active form because they have that particular variant of CYP2C19, are we predicting future increased costs for them? Are we predicting increased mortality? And again, thinking about this predictive diagnostic distinction, if I see someone in the clinic and I establish they've got loss of function in this gene that converts a drug like clopidogrel to its active form, am I diagnosing them as a poor metabolizer, or am I predicting in some future context, which may never materialize, that they won't be able to respond to clopidogrel in the event that they need it? So we simply don't know in which box that kind of information would sit, and that's, again, a challenge to that distinction that the code draws between predictive and diagnostic testing. And it's also worth bearing in mind that just like diseases, just like traits, like our BMI or how tall we are, things like how long we live and the amount the health system will spend on us are heritable. So it's definitely the case that genotype is related to coastal mortality. And you can imagine, in principle, an insurance company would be very interested in getting hold of that information if they knew that, say, a baby born today would be incurring very expensive treatment costs when they're middle-aged. And maybe you might not want to insure that person. Maybe you want to charge them higher prices. Excuse me. So that's giving rise to a risk of discrimination, which I think society absolutely needs to manage. So in that case, do we want the insurance company or insurance industry to have free rein to say, based on your genotype, I don't want to insure you, or I want to charge you higher prices? On the other side of the market, if we can't access that genetic information, then we may get something called adverse selection. And this is where high-risk individuals, and we're thinking about high genetic risk individuals in this case, prefer more generous or comprehensive insurance plans. And I'll just explain that with an example on this slide. So this lady lived in Michigan in the United States, and her mother died from Alzheimer's disease. And aside from the human burden, aside from the clinical consequences of the condition, there are also financial consequences, especially living in the US. So I believe her mother was in and out of care homes, then increasingly only living in care homes, and it became extremely expensive. So the lady pictured sent off a saliva sample to a direct-to-consumer genetic testing company, and the results came back that she also, in addition to her positive family history, carried the 2 risk-increasing versions of the ApoE4 gene for Alzheimer's disease. And as a consequence of having this information, so she's a much higher genetic risk already because of positive family history, and she's got the risk increasing alleles in ApoE4, she immediately took out insurance to protect her from the financial consequences if she ever develops Alzheimer's disease. And I think in her situation, most of us would do exactly the same. So the issue is, if insurers can never know our genotype, and there are arguments that they should or they shouldn't, but if the only people who ever take out, for example, long-term care insurance in this case, are people who know they're at high genetic risk, then it may become simply too expensive to insure these people. So is that realistic in the UK? Well, I don't think it can be ruled out. So the code especially applies to life insurance, income insurance, and critical illness insurance. And if you look at the insurance comparison websites, if you go to different insurers, you can get specific products that protect you from things like dementia and, of course, other critical illnesses. So if this was a concern, you could establish your APOE4 genotype and take out insurance on that basis. And because of the code, that's a predictive test which doesn't need to be disclosed. So you would never, at the moment, under the code, need to disclose the fact or disclose your APOE4 status. And I think, again, if it is a concern, you'd probably be well advised to take out some of this insurance on the basis that you don't have to disclose it, but you are at much higher risk than the general population. So from the industry's perspective, this could be a little bit of a challenge because if the only people taking out this kind of insurance, again, are people at very high risk, then it's simply going to become more expensive. And I think society might need a way of managing that risk. As it happened in summer last year, the government opened a consultation which closed in the autumn, and there are two topics up for discussion. So whether the definitions for genetic tests in the code remained up to date, so that's predictive and diagnostic, and then a proposal to change which predictive tests needed to be disclosed under the code. So the framework they proposed about whether a predictive test should be disclosed had 4 questions. So just very quickly covering this. The first question is, how useful is it for characterizing the risk of developing a condition? So that might touch on things like penetrance. How many people take the test? So maybe if hardly anyone takes the test, we shouldn't worry about it. Then what is the impact of the condition on people who develop it? So again, you might imagine if a condition isn't very consequential for health or how long we live, then maybe we don't need to get too excited about it. And then finally, is there potential for reducing the risk of developing the condition and managing its effect if it develops? So can we prevent the condition by using an intervention, and can we manage it? And I think on the face of it, this maybe looks fairly reasonable. Again, if you remember, the only predictive test that needs to be disclosed under the code today is Huntington's disease for life insurance over £500,000. But I think going further, if we take these proposals in a particular interpretation, it could seem that almost any predictive test could be disclosed because it's not clear how they'll trade off against those different criteria. So if very few people take a test, but it's very penetrant, then does it need to be disclosed? That's not clear. And I think there's a risk that maybe any and all predictive tests wouldn't need to be disclosed, and we need a much wider discussion. It's also proceeding on the basis that diagnostic tests can be easily distinguished from predictive tests, which I think is increasingly questionable given the way or given the volume of genetic information we're getting. And it's not clear if you have a test, again, that, there might be interventions available that could help manage it, but the condition isn't a very common one. So I think we need a much wider discussion. And we, with some colleagues at Oxford, put in a response to the government in the autumn expressing some of those concerns. And we're due to, we don't have exact timings from DHSC on when they'll issue their response to the consultation, but we're expecting it in the spring or hopefully before the summer. If the code is to change, and I think there is a fairly good case for at least considering how it might change, how would we go about it? And I think the starting point is to have a conversation, just like we're having now, thinking about these issues, exposing them, assessing their consequences. So should we treat genetic risks exactly like other risks? So if I'm a smoker and I disclose that to a life insurer, they treat that in a particular way. Should we treat, the fact that I might have a genetic risk to have a longer or shorter lifespan? Should we treat that differently? That's a normative issue. I think it's for society to consider whether that's fair. So in 2012, the European Union banned the use of gender, which you could say is determined by genetics, in insurance. So historically, women drivers have fewer accidents than male drivers. That meant their insurance premiums are lower, and the European Union said this is unfair discrimination, so let's not do that anymore. The consequence of that is that then women end up paying more for their car insurance. So is that the kind of direction we want to move in for these risks? Another philosophical way of approaching this is society could say, let's minimize the overall cost of insurance, but we'll help people who would otherwise have very high risk. That's one way of attempting to be fair, I think. Another way would be thinking about identifying people who have some sort of genetic burden, which we could define in a particular way, and then help those somehow. Either let the market proceed as it would, but step in particular cases, or have different kinds of oversight for the market, or not have the market involved at all, which would be, I think, a fairly radical solution that not many people are thinking about. But I think that there is a role for the state here that might be greater than has been anticipated in the past. Colleagues at the Centre for Personalised Medicine in Oxford and I are leading the organisation of a workshop in May at the Wellcome Centre, the Wellcome Collection on Euston Road, in collaboration with the Society for Genetic Medicine. Keep an eye on our website if you're interested in attending that. We've also written a paper which is freely available, which is below, talking about some of the issues I've touched on. And I think a takeaway is summarized in the second half of the title of the paper there. It is getting increasingly complex, and there are new challenges. There are challenges, potentially inadvertent disclosure, people doing direct-to-consumer genetic testing and not realizing this can be used in particular ways by insurers. So that first bullet point is just saying that I think the importance of the importance of insurance in conversations with patients could well increase. It's probably going to become more complex. I think the government is sensitive to some of these issues. I'm not sure if their consultation proposal was very well posed. At least they consulted on it. They aren't changing the policy without thinking about some of the consequences, but let's see what their response is. And hopefully the consultation and some of the responses they get will support a wider discussion on the type of principles that society thinks should apply to the use of genetics and insurance, and the type of outcomes that society would like to see if genetics is used in a different way or a more intense way in the pricing and accessibility of insurance products in the future. Thank you very much.
Thank you, Porrick. That was brilliant. That's such a complex subject, isn't it? And the impact for our patients are huge. I'm a cancer nurse by background, so insurance is one of those things at diagnosis or treatment that you do have a discussion about. It's quite routine, and I've listened to many patients talk about that phone call to the insurer and how long it takes, and the questions that are asked in a way that the person asking the question often doesn't know the implications of what they're asking, and it can be very distressing. So you add in this genomic influence, and it's quite mind-blowing. So thank you. That was a really good summary. Have we got any questions? Let's have a little look. Pop your hands up. We've got a comment from Amanda. Really useful information. Thank you. Yeah, requesting an email. So any questions from anyone?
Yeah, so I think I see a question about anything specific about Lynch syndrome and insurance, and there's nothing specific in relation to the code or Lynch syndrome being treated differently from other conditions, but it is an interesting one. I guess so. That's potentially an example of something where you might see a blurring of the distinction between predictive and diagnostic tests. So positive family history, do you go and get the tests? Are you being dissuaded from getting the test over concerns for insurance, or sorry, diagnosis over concerns for insurance? So there isn't anything specific in the code about Lynch syndrome, but it may well be a really good example of where thinking needs to be very, very careful, given that there's a lifelong burden and not everyone at risk will necessarily develop it. But of course, once you develop it, then you're really requiring a lot of intensive care. And there is an example which we mentioned in the paper of the emergence of AIDS in the 1980s and the life insurance industry. So to get a mortgage, you needed life insurance. If you had AIDS or if you disclosed that status, then it was a very difficult conversation with the insurance company. And there were reports of people not establishing their HIV/AIDS status for fear of being denied access to life insurance. And of course, in that context, you're talking about an infectious disease, and people not getting tested is a very, very bad outcome. And I think that was a case where the discrimination, there was a new challenge, there was uncertainty, there was a degree of ignorance, there was fear, and one of the outcomes was discrimination, which could have been avoided with maybe wider discussions and a bit more evidence at the time. So I think that's one of the sort of dynamic processes we'll need to keep an eye on.
I think we've got a raised hand from Annika, our next speaker.
Hi, sorry, put my camera on. Lovely talk, Porrig, thank you. I suppose I just wanted to reinforce your point about merging of predictive and diagnostic. And Lynch, I think, is a good example, but as would be BRCA, other cancer predisposition syndromes, because you could have a diagnostic test in the sense that you've got a young onset bowel cancer in Lynch, but that diagnostic test then predicts that as a woman, you've got a very high risk of womb cancer. So what is it? Is it diagnostic or predictive? I think we need a lot more debate on that. I think it's both, but how the insurance industry will deal with that, I'm not quite sure.
Yeah, and there's a comment from Ellie in the chat which touches on that again, about whole genome sequencing, which might originally have been undertaken for diagnostic purposes, but all the incidental findings could, from one point of view, be interpreted as predictive. And that's yet another example of this blurring. And I think the framework needs some very careful thought in thinking about this, which hopefully we'll get there in the end. But yeah. And yeah,
maybe we could say that if anyone has a particular interest in this area, do let us know, because there are some possibilities for attendance at the workshop. They're not unlimited, but do get in touch if that's your thing.
Well, there's a lot of interest in the chat, I think.
Yeah.
I think there's a comment there from Kelly about whether it works the other way, and that if your genetic testing suggests a lower risk, would this be beneficial when it comes to applying for insurance?
Yeah, and I think it's that's an underappreciated element in this conversation, because sometimes people assume that it will be unambiguously negative for patients and consumers of insurance products if genetic information is used. But if you, so I bumped into someone who's senior CEO in the UK life insurance industry, and his argument would be that life insurance is something that helps people be healthier. And if they are in receipt of information that will, lower your premiums, they want to use it. They want to help, help people have better access to insurance. So in principle, yes, it should be. But if it's asymmetric, so if you can only use genetic information to reduce the cost of insurance, is that sustainable for the insurance industry? And if hypothetically we're in a world where everyone had to test BRCA status, but they only disclosed it if it was favorable to them, then insurance companies could, in principle, draw the inference that the people who aren't disclosing are higher risk, and then you are back to square one. And again, I mentioned the gender insurance example. The European Union banned it in 2012. Many things are correlated with the risk factor that you might you're attempting to suppress its disclosure, but then you can infer it from other information that's provided. So, for example, men historically bought cars that are more powerful engines. So if you see 1,000 people buying an extremely expensive sports car, the chances are they're probably men. So even though you're not allowed to ask if the person buying the policy is male, say, hang on a minute. So all these things aren't easily written out of the risk pricing models of the insurance companies. Yeah, and there's a comment from Lucille about direct-to-consumer testing, false positive, negative results. You know, I'm not sure there's data out there at the moment about the extent to which people are having conversations on DTC results and then inadvertently disclosing them to insurance companies. I think that would be useful a useful little project to find out. There are a couple of examples from Australia where the regulatory oversight is different, but people, you know, being refused travel insurance because the relative is, or they've done DTC, they've found slightly elevated risk for something that they don't, for a phenotype they don't express. Yeah, the issue about consenting, also hindering patients from consenting, because I think possibly it is something that's going to become, well, it is going to become more important in general. And I think if you do need to put that out there at the consenting process, then yes, absolutely. Oh yeah, and yeah, Miranda, you've said it is something talked about during mainstream consenting. Yeah, really interesting to know.
Yeah, Kelly's made a comment, hasn't she, about not being able to, or getting extortionately high prices because of a family history.
Yeah, and again, it's worth saying, you know, keeping everything in perspective, family history can be asked about quite legitimately by insurers. And often the incremental information about your risk that's contained in genetic information might be zero or it might be very modest. In some cases, it could be quite a big deal. So these issues aren't just about genetics, but yes, always bearing in mind that the extra information compared to family history might be quite small and might not be consequential. And if the government is stepping in for this, from your comment, Beatrice, that will have to be paid for, and that's fine. It would be taxpayers paying in that case, and then I think we need a conversation about should we do it, for which conditions, to what extent, is it going to distort the market? So if everyone needs, well, if many people are requesting support, then private insurance might disappear, and then you have the government doing things that it may not want to do or may not have fiscal capacity to do. So that's, I think, an example of what are the normative considerations that enter into this, and should we be treating genetic risk differently from these other risks that we all face? And if it is some genetic risks, how would we identify those and treat them differently from you know, because you know most diseases have a genetic component, and yeah, we do want to be careful about inadvertently falling into the world of private healthcare, Charlotte, by good intentions to support people.
Phil, I think you've got your hand up. Got a question?
Yeah, I'm trying to figure out my question in my head, but it is really just thinking. Thank you for your talk, Padraig. But really, it's just thinking the newborn or the generation study that's coming into play, coming in soon, and these babies that we don't know. There could be nothing wrong with the babies, and we're doing genomic testing and whole genome sequencing testing, and that information is potentially going to be in the medical records for life. What are the implications there for, you know, I don't know, is that a predictive test for other family members? Is that a diagnostic test? It's a diagnostic test, we think, for the baby, but, you know, thinking about the wider family and the implications for the wider family as well.
Yeah, all those implications are real, and they're all super live topics, and I think we need to have more conversations about them, because, you know, Annika will talk about this for the rest of the day if you give her a chance. But, you know, I was reading, you know, the 3 goals of the Millennium Study last night, and the first is diagnosis, and then it's like, oh, let's see what we have when we have lifelong information. Well, there's a lot of risk information that insurers would be interested in, and if the outcome of the consultation makes many more tests predictive, that are currently predictive today, are currently treated as predictive under the code, then they would need to be disclosed. And those 100,000 babies are, potentially facing risks that we haven't really anticipated in relation to insurance. Maybe it just won't be consequential. Maybe it'll only be a handful. Maybe the conditions won't really be of interest to an insurer that are, not the 233, whatever it is, but more generally. So it's a new frontier, and we have to navigate it very carefully, I think.
Thank you.
Yeah, it looks from
generation study. Yes, sorry. Okay.
Yeah, and it looks from the chat like these questions are already happening, aren't they? That clinicians are being asked about. There's a mention here of Birmingham Children's Hospital.
Yeah.
Brilliant. Thank you. Any more questions?
Sorry, I just have one more question. It's really what resources are available for patients who are encountering challenges with insurance coverage?
A great question. I don't know the answer because I'm just a little bit distant from patients, but it sounds like there should be more resources, especially if, as seems likely, the code is going to change, or the proposal will be to change it to make more predictive tests within scope. And maybe the GMSA would have a think about that, because yeah, I mean, it's all very well us talking about it, but if there are patients of real need to access those resources, then yeah.
And I suppose linked to that as well, and kind of linking to the first talk we had, is thinking about those people where English is not their first language.
Yeah, absolutely.
That's great. Thank you. If there's no more questions, we could maybe move on to our next speaker. Thanks, Porritt. That was brilliant.
Thank you. Thanks for having me.
Thank you.
So Karen, if you wouldn't mind.
Yeah, lovely. Thank you. So next up, we have Annika Lucassen. Thank you, Annika. Annika is Professor of Genomic Medicine and Director for the Centre of Personalised Medicine at the University of Oxford. She's also an honorary consultant in clinical genetics. Annika, thank you for joining us today. We're really grateful you've given up some time to come and speak to us. So I'll hand over to you. I think you've got your own slides, haven't you? So
yes, I have. Thanks so much.
Perfect.
And as Porritt says, he knows me too well. I talk about this all day, so you might have to shut me up. So let me try and share my slides. I'm going to try and do something that's beyond my technical skills. So I've got some reserves in case it doesn't work, because I've got an animation with patient voiceover, and I'm not sure whether I can get that to work, but I'm going to try. So I think I need to do, share screen and include sound, I'm told.
Yes.
So we're going to try. Let's see. But yeah, do keep me to time, please, because the animation might make me go over. So hopefully I am sharing. And let me put it into presenter mode. There we go. Can you see
Perfect,
that in the right mode?
We can see that. That's great. Thank you.
Great. So I was asked to talk about translating molecular genetic information into useful clinical information, which is a lot more complicated, as this audience will know, than is often portrayed in the sort of discussions around genetics. And move on my slides. So I think that genetic data is often presented as clear-cut, and I think there's multiple reasons for that. One is that we tend to think about our relationships with other people as being entirely genetic. So we're 100% related to our, mother, for example, and therefore we think that that there's something about the genetic code that predicts things very clearly. But of course, health predictions often aren't nearly as clear as that, and we are increasingly seeing a sort of blurring between genetic predisposition to rare diseases, where genetics might say a lot about the predisposition, and that to common diseases such as heart disease, diabetes, cancer. And then I think for each of those common diseases, there's a confusion also, because a subset of common diseases are caused by a very rare single gene, as we've already been talking about. Lynch and BRCA are both common cancers, but they're a result, a minority group is a result of a very strong predisposition. And I think that's really hard to get your heads around when all you're faced with is these sorts of headlines and adverts that make it sound very straightforward. And as if you could hold up a magnifying glass to your genetic code once you have all of it and just know what diseases you're at risk of. And I think many of you in the room will, you know what I mean, will agree that that's often what patients come expecting. And a lot of genetic work is about managing expectations to start with, to be able to have a conversation about. And I think it's not just adverts and headlines and our patients, but it's and professionals, I should say, but it's also the general public as a result of that. And this is a paper that's a few years old now, which did a YouGov survey of the UK general public and their views about using genome sequencing in healthcare, and what that might mean for clinical practice. And what comes out of that survey, I haven't given any details, is that people, as a word cloud should show, is that people imagine that overwhelmingly it will be informative, personal, helpful and predictive, and the words like reliable, scary, problematic or worrying feature much less in the response that the general public give about these developments. So I think that's worth bearing in mind. And I think the other thing is that with the developments in technology and these huge leaps and bounds that we'll all be very familiar with over the last 20 years, is that there's sometimes also a tendency to think, well, it's all about technology, and as long as we can get all that stuff in a sort of black box of technology sorted out, we can go quite seamlessly from sample to result, and we don't need to worry too much about anything around it. And also the black box is a bit techy, so we don't quite know what's going on in there. We don't quite know how to how much patients need to know about exactly what's going on in there, what it means. So I think there is it's quite possible to focus on that sort of black box over the much more important thing that you've already talked about, is the clinical context in which these results are found. Because of course, if you find a BRCA variant, for example, in a man, that's different to finding it in a woman, or has different implications to finding it in a woman. And if you find it in a baby, it has different implications to finding it in an adult. So the clinical context in which genomic variants are found is much more important than the popular discourse about genomics might have you believe. And I've just put at the bottom there an example of some podcasts that we've run in the Centre for Personalised Medicine. This is episode 2. There's a link to it. I'm really happy to share those links in the chat later. And why context matters in genetic testing, that tries to give a bit more description about how important, how a variant can't work alone, and the context in which it arises is important. And then I suppose another way of saying this is that we've moved from this sort of manual looking for a needle in a haystack to a big combine harvester approach. And the picture on the right is often seen as more glamorous and efficient, and the process we need to follow, which I think is absolutely right. It is more efficient, and it is a way of scaling things up. but it doesn't mean that it's any easier to find the needle in the haystack, the manual approach and the big approach, because it remains difficult to pursue that analogy, to distinguish a sharp hay blade from a needle sometimes. And then it doesn't matter what approach you use, but certainly you'll get more haystacks with a right-hand approach. And I think private commercial companies have been very good at saying that, or giving the impression that clinical genetic services are sort of quaint and old-fashioned by using the left-hand side approach, whereas the way we need to go is using the right-hand side approach. But remember that if we're trying to give it a clinical meaning, that context is the important thing, not so much the process by which we arrive at it. And I think we all know that genetic diagnoses are often made over time. They don't pop out of the black box because of technology. They require several steps. And so it starts off by trawling through our genetic code and evaluating the variants that are found. And that's a very different process than starting with really strong family history, say, of, just to stick to the theme, of young onset bowel cancer. Then you might not need a whole genomic analysis in practice, because you can go straight to the linked genes and look there. But if you're starting with a genetic code and then forming the questions from that, you really need to wade through all the different variants within that code. And that exposes our ignorance about what much of this variation means, with what certainty, over what timescale, and in what clinical context. And the clinical picture, the signs and symptoms, the family history, can help exclude many variants. And exclusion is often impossible from just having the variants from the code. And that's complex and exploratory in nature. And the ability to see other information means that research and clinical practice become entangled. We've already talked about that in the newborn sequencing. I'll go on to say a bit more about that in a minute. But I think it's really important that we are very clear that uncertainty is not a failure. It's a difficulty if it's not addressed openly. And honestly, in the face of those very deterministic types of discussions and those headlines that make it sound clear, but it's all about starting at the point of saying this is much more complex and uncertain than you may have the impression of looking at the public discourse about this. And I think we need to do that with our patients, but also with our colleagues who, not surprisingly, I think also quite often have overly deterministic views of what a genetic test can show. So I'm just sort of putting this in plain, or in sort of variant speak. If you take an average whole genome sequence, these are the types of things that you will find. This is a lot of this comes from UK Biobank data of healthy people who are healthy adults who have no known genetic conditions or no severe illnesses. So we all have, every one of us has between 4 and 5 million variations out of the 3 billion letters of our genetic code. And then on average, we'll have about 200 very rare coding variants, so in parts of the genes that code for proteins. We'll have 27 novel coding variants that are not known in big population studies, 85 heterozygous protein truncating variants that are predicted to disrupt and potentially inactivate genes, 35 homozygous protein truncating variants, so that a person may have no functional copy of that gene, 7 rare non-synonymous coding variants in dominant monogenic disease genes, and 54 variants previously reported in research papers or other databases as disease causing, but in the absence of any obvious disease. Now, it's important to say that these are overlapping categories, so and they've been gathered from a range of different papers. So it's possible that you've got one variant in more than one category, but I'm just trying to highlight how much more complicated it is than the good old days where we were just looking for one particular variant in the cystic fibrosis gene, for example. Hopefully you are all really familiar with the Genomics education website, which has fantastic resources and explainers, and please familiarize yourself with all corners of that website. I've just picked one example here of something I think is really important, that the process of diagnosing rare disease can be a difficult and frustrating experience that comes with uncertainty, multiple referrals, diagnostic wrong turns, and unnecessary and sometimes invasive tests. And I think that is true plus or minus genomic testing. And I think sometimes genomics can provide an end to a lengthy diagnostic odyssey, but often it is just part of that lengthy diagnostic odyssey. And at other times, they might even create one rather than end one. So I think it's really important in the sort of optimistic discourses about diagnostic odysseys that we remember that. And yeah, just picking up on the newborn whole genome screening, I think that's really important to have a bit of a discussion about, because I'm told that recruitment will start in the next 2 weeks. And I think this is an interesting one, isn't it? Because it's part research, part NHS embedded screening, and it's not always clear which bits are which. But what it's doing is it's starting with a whole genome rather than starting with a clinical context or symptoms. It's saying, here's a seemingly healthy baby, and we're trying to get to that baby to predict or stroke diagnose a genetic condition whilst an intervention is still possible. And what's not to like about that rhetoric? But what we need to be really careful about is that we often assume a very high sensitivity in these sorts of approaches, i.e. that we won't miss any cases, as well as a high specificity, i.e. that we won't falsely diagnose any cases. But there's always a trade-off between sensitivity and specificity. We cannot get away from that, even with a whole genome sequence. So more sensitive approaches will generate more uncertainty and ask more of already stretched NHS resources. And more specific approaches, we will need to make really clear why we're using a whole genome approach when a limited panel would be a much more effective, cheaper, more environmentally appropriate way of giving the same information. And I think the next point sort of says something similar, that current thresholds are set very high on the heel prick test that we have for newborn screening, and it's often argued that whole genome sequencing allows us to expand that. But actually, that's not true. That heel prick test could be expanded for many more diseases, particularly metabolic, genetic metabolic conditions. But that hasn't happened because the National Screening Committee hasn't thought there's enough evidence of benefit. And so that's really important to remember in that discourse about, isn't it great that we're having whole genome sequencing of newborn babies, because it hasn't then gone through the same process as we've been used to new diseases going through for the National Screening Committee. And I think a really important question is, might we divert resources from currently unwell babies with rare conditions who are already waiting very long times? And Rachel Horton and I wrote a piece in a journal called Precision Medicine, and again, it's open access, very happy to share that, about some of the issues that we need to be thinking about when we're using new genomic technologies in newborn screening. Some of the points we drew out there, I think already sort of partly come up in discussion, is that we know from adult biobanks that the link between genomic variants and disease is often less strong than we had thought. So what if you find some of these many variants in that box that I showed you in a newborn baby? Do we disclose that? How certain can we be that they're really going to result in avoidable newborn diseases? And the programme has, of course, been hailed as ending diagnostic odysseys, but it may indeed start many diagnostic odysseys that would never have happened otherwise. And Rachel's cartoon on the right-hand side is trying to illustrate that a baby is found with a predisposition to a heart condition that's disclosed and followed up throughout their lifetime, but they've never been ill. And so what benefit did that particular baby have throughout their lifetime of having this picked up at birth? And I think we really need to be encouraging those debates further, because I think the debate has all been on the benefits so far to get the programme started. Now we need to be very careful that we don't inadvertently cost the NHS a lot more time and effort without overall benefit. And one of the things we've been doing as a research study is qualitative longitudinal research in participants and their families, and been interviewed repeatedly over a 5-year period since recruitment of the 100,000 genome study. And Phil, thank you, you've been very helpful, I think, in recruiting some families for this research. But part of our reason was to look a little bit at that sort of diagnostic odyssey ending discourse, to say that even participation in the 100,000 Genomes project, which was sold as ending those diagnostic odysseys, often started a different diagnostic odyssey, or didn't quite end the odyssey in the way that was expected. And so for many, the experience with genomic medicine was encapsulated by them as protracted and uncertain, with long waits, negative results, or other unclear messages. And what was very interesting was that biological and social linkages became much more obviously entwined than you might think just from genomic testing. And one way of sharing some of these really extensive interviews is through illustration, and we've worked with an artist and our participants to co-develop and produce illustrations of these journeys. I think it's really important to share their experiences of genomic medicine and how they shape and are shaped by the broader context of their lives, because we don't often see that evidence. We see people coming to clinic, we see them once now, we rarely see them for follow-up or develop a relationship, as I might have done at the beginning of my career. So I think these stories are really important. And we've published that in this reference here. I don't know how I'm doing for time. I don't know if someone will squeak if I'm running out, I hope. And here are some. We've got about 30 of these now that are summaries of these interviews over several years about what their genomic journeys means for them. This is Rachel. These are all anonymized, so that's not her real name, whose journey began after her symptoms changed in her 20s. And actually genomic testing resulted in the loss of the diagnosis she had lived with since infancy, and that had lots of very surprising implications for her. Very happy to share these so you can have more detailed look at them. And then this is William and Maggie, whose journey focused on exploring a genetic cause of William's neurological condition that could have implications for the lives of their children. And this one we've put to an animation where William and Maggie themselves speak about this journey. And I thought I'd share that with you because it's so much more powerful to hear it in their voices. So I hope this works, and if it doesn't.
I am Maggie and I'm married to William, and we have 2 grown-up children. William has a neurological condition and had his genome sequenced to look for a genetic explanation. In this sense, William is the patient, but our journey through genomics is collective. This is our story. William's symptoms started in his early 40s. The physical changes happened very gradually and we didn't acknowledge them at first. But one day in the garden, when William turned to talk to me, what should have been a natural movement was awkward. We both saw it and realised that something wasn't right. We sought medical advice and were referred to a neurologist who suspected a genetic cause because of William's family history. William's father had similar symptoms, although at the time we'd never thought they could be hereditary. Growing up, different family stories were told to explain Pops's condition, like being repeatedly hit on the head with a sailing boom, or from having mumps which caused encephalitis as an adult. But when William started with similar symptoms, these stories unravelled, and we began to question the genetic nature of Pops's condition. William also started to think about his own past and wondered how his experiences had been affected by his condition. Had he had to work harder at sports and balance than others? After targeted genetic testing didn't find anything, William had his genome sequenced to continue the search for a genetic explanation. Our children are at the heart of our story. The importance of finding a genetic cause comes from the implications it holds for them and our future grandchildren. We want to find and share as much information as possible to help give the children choices. If it was just about William, he might not have had genome sequencing. The genetic aspect is not important for how he makes sense of his condition for himself. William has a pragmatic approach and focuses on adapting to the physical challenges his condition presents. The way he sees it,
if I'm at the top of the stairs, I can either stay there or find a way to get down.
He continues to seek new ways to carry on living life to the fullest. He recently took up golf and he always says,
I just have to keep my feet firmly on the ground.
William's physical limitations are less obvious when he's not standing. He tells us,
when I'm sitting or lying down, I'm just the same as everybody else.
A few years ago, we got a letter saying that the genome sequencing had not revealed a genetic cause. At first, we were relieved, as we thought we were being told that the condition wasn't genetic after all. But when we spoke to the neurologist, we realised we were actually being told that it is genetic. It's just that the specific genetic causes are not yet understood and may or may not become clearer in the future. This realisation was a real low point for us. We went from believing we'd reached the end of our genetic search and feeling very hopeful for the children, to realising that our journey continues with unanswered questions. So now for us, it's about finding ways to accept and live with the uncertainty of what the future may bring.
So all credit to Kate Lowell and Susie Weller, who led on that research.
I am Maggie.
Oh,
and I'm married.
Didn't mean to do that. I'm going to skip over the next two slides because I think they've been very well covered by Verleen this morning. But just to summarise that we have a problem with diversity in genomics at present, and despite calls to change that hasn't really changed. I just want to finish by mentioning something that many of you will already know about and hopefully have been to, is the Genetics Forum, which is a forum that has been running for over 20 years now, that Mike Parker and I, Tara Clancy and Angus Clark set up, that's had nearly 70 one-day meetings where we bring together cases from around the country, or indeed more often now outside the country as well, particularly with virtual meetings, where people are struggling with some sort of issue that's arisen in their practice. And the discussion of those issues has been a fantastic way of creating ethical standards of care in genomic medicine and seen an evolution as the technology has evolved. It'd be really great if, I think the next meeting is going to be a virtual one, so a bit easier for attendance. But if anyone is interested in coming, please do email this email address, because I think you'd find it really interesting in how the context of genomic practice affects how we handle cases. And some of the, just flashing up some of the guidelines that have come out of genetics discussions that some of you will be familiar with already, and that they are guidelines that help us think about issues and help us be prepared to deal with the different context in which genomic medicine arises. And I think I will just flash over that to my last slide, which is that the scientific and technological advances of course, promise big improvements in healthcare, and that enthusiasm about these advances is really welcome, but that we also need to focus on making the future of genomic medicine realistic by shaping it in the here and now. And how genomic variation contributes to disease is complex and often much more so than patients or colleagues expect. And we need good interdisciplinary empirical and conceptual research, policy and public dialogue, clinical engagement to understand and respond to these advances in a comprehensive way. Thank you very much.
Thank you so much. That was brilliant. We've had a lot of requests for sharing the papers and references that you've used, which hopefully if we can share your slides, we will
of course,
get those sent
yeah.
to us. Thank you. And then we have a question, I think, is that from Phil?
Hello, Annika. Thank you so much. You can talk all day and I can listen to you. Because everything is so interesting, and it just makes you think outside this really positive box that we sometimes get. And I think I have two main questions really. Is number one, it's about those consent conversations that we're having with patients and about managing their expectations. And also thinking about, because with whole genome sequencing, we have incidental findings potentially with a whole genome sequence. But how do we then support those staff that are having those conversations, how they handle the communication skills, especially when mainstreaming is kind of on the agenda and we're having to do it within, we need to mainstream as quick as possible. That's how it feels sometimes. And all these different conditions. It's about, my question is really, what do you think about how fast we're moving and how much training we're getting in these conversations to support patients, really?
Yeah, I think that's a really important question. My sort of instinctive response is to say of course we need to advance, of course we need to mainstream, but we also need to remember that here patients are embarking on a journey, and it's a complex journey, and therefore consent conversations can't do all the ethical work that we want or we know needs to happen in these spaces. So I think what we can best do is support our colleagues having those consent conversations to really illustrate that this is not like you're going to have a blood test, I need to know whether you agree with it or not type conversation. It's much more, here's an investigation that may seem just like a blood test, but it's actually really complex. There are lots of things that it might find over time. It might say things about you, it might say things about your relatives, it might give you an answer to a question, or it might give you an answer to unasked questions. And so to make it much clearer that this is the start of a journey, rather than a sort of toggle into a yes/no answer.
That's great. I think based on my experience that sometimes what the patient hears is probably where that doesn't really come across very well.
I think that's absolutely right, but maybe that's also our fault for wanting to get a load of information packed into a sort of toggle event to know whether to go forward or not. And I think that's another reason why we need to be clear that this is not a sort of one-off sort of tick box event, because of course patients won't remember what has been said. Most patients don't remember what's been said in any sort of straightforward consultation. I don't, I think you retain at most 3 facts. And as someone who, works in the medical profession, you'd think I'd be quite sort of familiar with what might come my way, but you don't. You had the experience of sitting in an appointment with my mother-in-law recently, where we recorded it with consent of the clinician, so that we could play it back, and both of us had forgotten a lot of stuff that was said, and and that was a very routine appointment. So it's going to be that with knobs on for genomics, isn't it? And we just really need to move away from this sort of, we've got to get a signature on a form or a thumbprint or a tick box done, because that won't in the long run won't work and will get us into more difficulties, even though it might feel like right now it's the cover that we need.
Yeah. And sorry, I know Charlotte's got her hand up, but I have got one more thing. The animation and the video are extremely powerful. And I think I'm hearing more and more and more about how animation is so important in getting the message across and raising awareness. And so I'm going to go on. What about those in other languages?
Oh, yes, that's a really good point. I don't know. We haven't even started that yet. We've still got 30 other journeys that we're still analysing, I suppose. But yes, we do need to think about translating those. And I'd love your thoughts about how we might do that.
Thank you. Thank you very much.
Thanks, Phil.
Thank you, Annika. Much the same as Phil in a lot of ways is around the translation, because one of the things I was just thinking about was brilliant to have that. Very much suspect, though can't tell, that that was white British male. But we do have patients, and this afternoon we do have some patients who have their own experiences, whether actually it might be good to have them on an animation talking in a different language, one that they might be conversant in. I know that we've had members of our own team who've looked at some of the information sheets and have said, oh, that's written in highly academic language that I don't understand with my fairly basic knowledge of Urdu or whatever. So I think that's part of that. But I think one of the other things that I wanted to say was, I do think that we are very much at risk of overwhelming patients sometimes. If you look at the cancer component of what we give to patients, they've got their Macmillan books, they've got their appointments, they've got here's what to know about this. And I feel that for a lot of rare disease patients, that must be much the same, that there's all this information about what we could do with doing the testing, what it might involve. And I think some of this for me is, I was on a meeting one day and someone was talking about our new thing, the clinical pathway initiatives. And somebody from NHS England said, well, we know we've succeeded when the staff know about everything. And a patient was on that and they said, no, you haven't. You've totally missed the point. Absolutely missed the point. We have succeeded when actually the patient and I understand what you are going to be doing to me. So I do think that it's incumbent on us as the professionals working within genetics and genomics that we focus again on, yes, we need to know, but we need to know so that we can clearly explain to a patient. So that was just a point I wanted to.
Yeah, I think that's very true, but we must be very aware that in our drive to make things clear, that we don't promise the wrong thing, I suppose.
Absolutely.
And, I think Joe's point, saying there's so much more that affects what patients take in, such as environment, who else is in the room. And that's as important, we might sort of know that from, say, going to a GP. GPs will be very familiar with thinking about other things, but we're not so good, I think, at doing that in genetics and genomics yet, because of this focus on what's going on inside the black box. And I think if only we can be a bit less enamored with the technology. I mean, having said that, that sounds like I'm sort of against technology. I'm not at all. I'm just trying to say that,
I think we understand what you're saying.
We need these advances, but then we need to also put them into a real life context and make sure that we don't give the impression, which people will already have from headlines and from their own experiences, that this is going to be a straightforward, clear-cut answer, when actually it's probably going to be anything but that. And the thing I'd say about, we've got a real diversity problem in genomics, and that's made, and it's all sorts of diversity. It's not skin color, language, it's, it's socioeconomic, socio-demographic, political. So there's all of that, but I think, and we need to be very careful that we're not creating resources that worsen that. but we also need to be careful not to create no resources for fear of doing something there. So we will probably, in countries like the UK, have to start with animations in English and then think about translating them rather than start in Urdu, for example. I mean, Phil knows my bugbear here. English is not my first language, so I think that's a euphemism to say. I mean, when we say English is not first language, we mean haven't got command of the English language. I hope that I've got good command of it, but it's not my first language. My mother tongue is something different. So I think we need to be careful not to lob in euphemisms and say what we mean here. What we're after is not widening the disparities that are already widening by themselves. So we just need to keep a really careful eye on that.
Thank you so much.
There's loads of comments coming on. Is the animation publicly shareable, available? Really good question. It should be very soon, and I think it will be on the CPM website. The reason I haven't shared my slides in advance is because with the animation, it's massive. So what I'm going to do is send to Donna. I'll send the slides without the animation. Even then, I think it's too big to send my email, but I'll find a way of getting it to you and then let you know as soon as I know the link. And that the slides will have all the links to the papers that I told you about, and they're only open access things. And then as soon as the animation is publicly available, I'll let you know where that is.
That's great, thank you. And we'll make sure we get those out. There's lots of ways of moving big data now, isn't there?
Yeah, it's just that I'm not very good at them, but I can find someone who is.
Just about time, we've got a break at 12. Any last questions coming in? A few comments about how things are being done well in clinical services, and but also again just recognizing that it is very overwhelming for patients and families, and we can't be what's the right word, complacent, I suppose, that everybody is going to listen and deal with things in the same way. Okay, if there's no more questions, shall we start moving towards our break? We've got thank you so much, Annika, that was excellent.
Pleasure.
Brilliant, thanks for coming along. And we're gonna go for a break until 12:15, I think it is, but we've just got one very short video to share with you, which is about Rare Diseases Day and a little reminder of the patient perspective and why we're here today. And when you come back from the break, we're lucky to have two of our patient family representatives here to talk to us. So thank you.
Thank you very much, Annika. So I'm gonna hopefully, can you let me know that you have sound as well? I'm gonna
Hi everyone, I'm Raquel.
My name is Nate Milam.
My name is Logan. I'm a volunteer from Italy,
Bahrain, India,
and Argentina,
from South Africa,
Malaysia.
I live with 6 rare diseases, 2 of which are genetic.
I was diagnosed with Loeys-Dietz syndrome type 2.
I was diagnosed with a hereditary colon cancer syndrome.
This disease made me 90% physically challenged.
Having learning and speaking difficulties.
He is living with a syndrome without a name.
Rare Disease Day creates visibility and community.
Research and unity.
Changing the world.
Strong together.
To seek new treatments.
Improve healthcare.
Awareness, collaboration.
Equity and more inclusion.
To create a better future for everybody.
Okay. So it's 12:15, so we're ready to move on, everybody. I think Sadia's here. I think I've seen her name. Karen, are you happy to
Absolutely. Yeah, hello. Hello, Sadia. think you're there. Yes, welcome to the second half of our webinar, and we're going to hear from our two final speakers who are going to share with us their personal experience of genomics within their families and the genomics journey that they've been on. So first of all, we have Sadia Haknawaz, who is she's a member of the Central and South Genomic Medicine Service Alliance Patient and Public Involvement Panel, and Sadia is going to talk about her genetics journey from PPI to PhD. So over to you, Sadia.
I'm just having a few problems here. Sorry, I'm just going to have to stop sharing for a second. But carry on talking, Sadia. Introduce yourself.
Thank you very much. Hi, everyone. My name is Sadia Haknawaz, and I'm going to share my genetics journey with you, PPI to PhD. PPI standing for patient and public involvement, so that's in research or policy to ensure that there's representation from those that have experience or interest. And just before I do start, I just wanted to give a little warning that some of the images in my presentation might be a little bit upsetting. They're not graphic, but I do talk about baby loss, and I just wanted to give that little warning beforehand. So next slide, please. So I'm talking about my daughter. So I lost my baby in 2010 due to a suspected condition called autosomal recessive polycystic kidney disease. It's a rare condition. The earlier that it presents, the more lethal it is. We found out in the 20-week scan there was no amniotic fluid, and I remember the sonographer saying that to me, and I knew exactly what the condition was. And I will talk more about that a little bit later on. So my daughter was stillborn during labour due to a cord prolapse. This pregnancy was quite special for me because I'd experienced some fertility issues, and I had a lot of miscarriages before this pregnancy. So it was quite special, and I decided to continue with the pregnancy. Every milestone was important. I had a son at that age, at that time, aged 6. So planned the birth and the kind of care that I wanted to receive, just because, you know, it was important for me for the baby to be born alive. Again, it was another milestone. And Islamic personhood, I really wanted the baby to be born breathing so that we could have a funeral. And so we made our plans, and I did continue. There was a lot of pressure on me to terminate the pregnancy. But I knew what we were expecting. I knew that the baby wasn't going to survive. So I just wanted to, you know, make the plans that I wanted to make. Maybe a little bit hopeful as well at times, because it was just that, let's wait for this baby to be born and then see what happens. It may have a little chance, but I want to give it that chance rather than give up on the baby. So that's what we decided. Unfortunately, not all my wishes were respected. I was denied a cesarean section on multiple occasions. My labour was a kind of like a start-stop labour, and the baby wasn't monitored during labour because I was told that we know that this baby is going to be distressed and we can't do anything about that. And then I was sent home, where I suffered a cord prolapse and rushed back into hospital, planning for an emergency cesarean section, until my consultant walks in and then tells everybody to stop, that, you know, she knows me and she knows the baby and it's lethal and incompatible with life. And then everything just kind of stopped. And I felt it was so unfair. And I remember those words, you know, lethal, incompatible with life, that, you know, someone can just say those words and everyone gives up on your baby. I just felt it was unfair, and that, you know, life was not valued and my wishes were not respected. I still had a fight on my hands. I still had to fight for an epidural. There was some pockets of good care. I won't say my care was really bad throughout. I had an amazing midwife who I met recently who supported me during that birth, and some good care afterwards. But it was just a very strange place to be in when you're pregnant and, you know, your baby's passed away, but you're still pregnant, and then you're being forced in a way to give birth. I didn't want to give birth because, you know, I'm not really giving birth. I'm not giving birth to life. And I remember thinking that this is really strange. I'm actually giving death, am I? You know, what is it that you're actually doing? So it's a very, very strange place to be in. But I did give birth, and like I said, some of the care I received was amazing. I had an amazing neonatologist. because it was important to me to get some blood, because I knew I wanted to get this, tested to find out exactly what it was. And just having some lovely conversations with the neonatologist who understood, my position and the beliefs of my family. And I went for a procedure which was an invasive procedure, which to extract some blood from the baby's heart, against like family advice, because it was important to me to have that blood. There was only a small amount of cord blood, so it's important for me to have some blood to carry out testing later on. I was pregnant quite soon afterwards, so we were fast tracked through the genetic testing service, and that testing revealed that my baby didn't have the faulty ARPKD gene. I did have it, and my husband didn't have it, so it was a bit of a strange scenario. But that pregnancy and the ones afterwards, it was always treated as me being high risk, having a 1 in 4 chance of having a baby with ARPKD, because it could have been, a mutation that wasn't found yet. So kind of not really an answer, but you have something to kind of go by, extra scans and so on during pregnancy. I did go on to have 3 healthy children, so now I have 4 healthy boys. Next slide, please. And the reason that I knew what this condition was prior to me losing my baby, my sister lost 2 babies to the same genetic condition. Again, the same thing, they were picked up at the 20-week scan due to lack of fluid. So in total, my sister lost 5 babies, 3 which were full term, and then 2 that she terminated after a CVS. And she could have a CVS because they all carried the gene. Her and her husband carried the gene, so she could have a CVS. That was an offer to me. I couldn't have that. We also had the family tested, and my mum and dad are first cousins. And I'm married on my mum's side of the family. My sister's married on my dad's side of the family. But when we had our family tested, both my parents carried this faulty gene. So in reality, they've had 7 children. It's a 1 in 4 chance. One of those children should have been affected. So they were lucky that, the children weren't affected. But then I always say, were they lucky? Because they've lost 6 grandchildren to ARPKD. So as a family, we share our story, we share our experiences. We know that it's a taboo subject, just to get people to understand the risks of cousin marriage. And I think we recognize the risk after I lost my baby, because before that, we just thought it was something to do with my sister and her husband, but really understood the risk, more clearly when I lost my baby. But it's quite surprising, because even after everything that's happened in our family, we still have people who've there's still been a close cousin marriage. So, people, they're free to make up their own decisions, but they are wary of you. So you talk about your losses, people think that you're cursed, and they're very superstitious of you. And then, there's always that stigma when you're in healthcare. Anything that happens to your children, the first thing that they'll say, oh, it's because of consanguinity, without going any further than that. And you almost feel, well, you do feel like you're blamed for your loss. After my loss, I felt like there was this hierarchy of loss. People are quite sympathetic at first, but then the more they find out about you, they start to judge you and blame you for your loss, because it's your fault. You're married to a cousin, and you take part in this practice. So you lose that sympathy, and you live with that stigma. Next slide, please. So my current status now is, because of those testing that showed it was an ARPKD, I'm back in the genetic service now, because I do have 4 healthy children, but I always wonder, maybe it's a different condition, maybe it's ADPKD, which shows up later in life, and I'd rather know and be prepared for something. But it's a long process. I'm not pregnant, so I don't get fast tracked through the system. So re-refer to the genetics, a very slow process. Maybe see a kidney specialist and see if there's anything else that they want to kind of rule out first. You go months without any correspondence, and I was really surprised to see the same referral forms from back in 2010. I guess there's probably nothing wrong with they're using the same forms, but I did expect like a digital version now, to be honest. And it is quite stressful, because you're just waiting for answers. You can't constantly it's like a waiting game. And every illness that my children have, I'm like, oh, maybe this is it, maybe this is something. So it's a difficult position to be in, but I wish someone could just speed up that system. Next slide, please. So this is about patient and public involvement. Like I said, you live with that stigma, and for me, things kind of changed in April 2021. Birmingham City Council released the Infant Mortality Scrutiny Inquiry report, and this report, I felt attacked by this report because it blamed the high levels of infant mortality in Birmingham on the British Pakistani community, and due to the practice of consanguinity resulting in congenital anomalies. I felt really attacked by the report, and there was no patient voice on there. And for me, as a patient, to believe in any recommendations, I need to know that this has been done in conjunction with, co-produced with patient on there. And there was no patient voice on there. And it really bothered me that I felt like our babies were being used as statistics, and I just felt like that was not fair. And I really wanted people to hear the stories behind those statistics, because they're important stories to hear. So I tried to find out who do I contact about this report, and it was something really difficult to do. There was no get in touch with us, email this address. So I had to really find out who it was that made this report, or who's involved in this report, and figured out it was public health in Birmingham. And then I decided to contact someone from public health, and I chose the assistant director, who was Dr. Marion Gibbon. And the reason I chose her was because she's not the top person. I thought the top person won't have any time for me, and the last thing I want is to be transferred from one place to another. And the name Marion, I thought, sounds like a nice person. So I sent just judging by the name, sent off an email. And this is Birmingham City Council, and I didn't expect a response. They're known for their really bad customer service. But shockingly, and I feel like this is a point in my life where that my life kind of changed, I received an email within 20 minutes, and Marion had heard everything I'd said. She agreed with all the points that I'd raised, and she asked me to join the Infant Mortality Task Force to be that patient voice that I was complaining about. And I thought, okay, now I'm going to have to do that work. I was complaining about no patient voice. Now I have to be that patient voice. But it was a great experience. Took part in a lot of meetings around maternity, women's health, health inequalities. Took part in raising awareness at schools, so just sharing my story and that of my family at schools, like year 11s and 6th forms, not young children, just sharing the risks of consanguinity and informing young people of the choices that they have out there, and most importantly, how to use your voice when you don't agree with something. And that was quite powerful for me, and got involved with PPI, so became a member of the Hilders at the University of Birmingham, and I was the first member to be involved in that work, which was just amazing, and it's focused around women's health. Lots of other projects around genetics, and yeah, I've just found this work very interesting and really powerful on my journey. Next slide, please. So this is where my journey changed. And from PPI to PhD, I saw an advert on Twitter about this PhD at the University of Leicester, and it spoke to me. The words, when I read up about this this PhD opportunity, it was just my life and my interest, and I felt like it was made for me. I just finished an undergraduate degree in early childhood. I did a module on research, which I found really interesting. And I just completed a community researcher training along with the work that I've done in PPI. I inquired about this, and I did meet the criteria based on my experience, and went through the interview, and I was surprised. I still have to pinch myself that I'm on doing a PhD. I'm in my 2nd year. I'm studying part-time, and it's focused around improving care for those experiencing 2nd trimester pregnancy loss and baby loss. And my research will focus on Muslim experiences of pregnancy loss and baby loss due to congenital anomalies, and this is because of all the stigma that's attached to Pakistani communities. It's not just Pakistani communities, there's like African communities, Arab communities, and I wanted to move away from that stigma. So this is why I chose my title as Muslim experiences. Next slide, please. So you just have to look at the headlines and see what comes up when you talk about congenital anomalies and ethnic minorities, like racism, Islamophobia, and you can imagine reading this and not wanting to get involved in any work, because again you feel attacked and you feel shame, blamed, and just misunderstood. Next slide, please. And then just recently, again, banned cousin marriage. It's always the focus on cousin marriage, like it never moves beyond that. We never talk about choices, reproductive choices, and testing or anything like that. It's always, let's ban this practice. You know, practice is not as popular as it was, but it does still happen. And you know, it's very difficult to put yourself out there when when you're faced with all these judgments. Next slide, please. And just in my research as well, coming across loads of articles from 20, 30, 40 years ago, and all the researchers, they'll warn you about how to conduct research around this topic, to do it sensitively, to avoid alienating communities. And any interventions need to be consistent and evaluated. The importance of patient representatives, patient voices like myself with first-hand experiences so people can relate to them. And it's important to do this to build trust, because trust has been lost for a very long time. It's really important to build trust around this topic so that you can have those really open conversations. Next slide, please. And then just some points that I raise about how to build trust to increase representation. And what I mean by that is to increase patient voices, in policy, in research, avoid alienating communities, and just more opportunities to be involved in research. There's so many barriers to taking part in PPI, to guide research, to understand those barriers. It's a very sensitive topic, and I think people want to share their stories, but you have to create those safe spaces for them to do so. And evaluation of interventions and like a bottom-up approach. I was involved in the NHS work on cultural competence in genetic services, and it's the 10 key priority areas around the UK. So I was a PPI member on the evaluation arm with Health Innovation Network. I was glad this work was happening. I mean, I don't know if I'd prefer a close relative midwife to a standard midwife, but that option's there for people who'd want that, want that support, which is absolutely fine. And surprisingly, I felt in my experience the genetic services were the most competent, culturally competent. So I didn't, understand why that was happening. Maybe it's something that's working that, is good to continue, I guess. But my work there, it was really good because I finally found 2 other parents who joined that group as a PPI person, and I'd felt alone prior to that because it was just me talking about my experience. Although I don't think these parents had experience of loss, they were interested in this topic. But the evaluation work was cancelled, and when I asked for reasons why this was cancelled, it was just because there was no capacity. So it felt like that PPI work was really tokenistic. There's no evaluation happening. If you think about the warnings the researchers gave, there's no evaluation happening. This work is happening around the country. There's a lot of money being poured into this work, but how do we know if it's working? You're not getting any information about the evaluation. So I just found that really sad, to be honest. And for me, it's probably one of the worst experiences of being a patient voice and feeling like your input was quite tokenistic, because this topic is close to my heart. And I'd have liked to see it go on. I believe in including people to make that change, and I felt like we could have done something really positive there. But we don't control everything. So that's one of the pieces of work that was really sad to see ended. Next slide, please. But yeah, it's not all doom and gloom. I'm still optimistic that we can make change. I'm still, I'm doing my research, and I'm still doing PPI to hopefully contribute to some change and getting some amazing opportunities. This time last year, I was planning on going away to Cape Town in South Africa to set up a global PPI framework around women's health, and that's just so far out of my comfort zone for me to do, and I can't believe I did that. But those amazing opportunities I've had because I was a PPI member, and again, working with so many amazing people, and I'm just constantly learning, and that's what I want to do. I recruit other PPI members because I want other people to have their say. So if you value your patient voice, you value your PPI, the people with lived experience, we can work together and have a positive impact. And I always say this little quote that, if I'm a single voice that's had a powerful journey because I was heard, because someone listened to me, imagine the possibilities and positive changes that can be made when many voices are heard. And that's what, I'd love to aim for. And I can't wait for the day where, I share the stage with someone else who shares their experience, because it'll take that burden off me a little bit. I'm not stopping because someone needs to continue and, represent those that are underserved and underrepresented. So yeah, I'm going to continue to do that work, and sharing my story with you today, and thank you for listening.
Thank you so much, Sadia. That's a really inspiring talk that you're given, such a sensitive subject, and to be so honest and upfront and talk to us today and talk to all these like names when you can't even see faces. It's hard enough when you can see people, isn't it, and be in the same room. So we really appreciate it. Thank you very much. There's lots of congratulations coming in on the chat. Any questions that anyone would like to ask Sadia? I've got one around. I think you meant, oh, hang on. No, somebody's popped their hand up. Charlotte. Charlotte?
You go first, Donna.
No, it was only, I think you mentioned about going into schools.
Yeah.
Yeah, I was just wondering how children respond to, I mean, I'm sure you adapt what you're saying to the children that you're with,
yeah.
But how did the children respond to what you were talking about? And also, do you think that's the way forward in how, because we do have, there does need to be a shift, doesn't there, in the way that we think about close marriages and everything really that's connected with your story.
It was quite positive, to be honest. So I was quite nervous going into secondary school. You know, the children are quite rowdy. These are like year 11s, and you know the conversations that you hear, and I was just like quite scared. But as soon as I started talking, you could hear a pin drop because everyone was paying attention. Like all eyes were on me. It's quite daunting, to be honest, but it showed that they were listening and they were interested, and they had lots of questions to ask. Like people could relate. Someone's lost a baby in their family, someone knows of a cousin marriage, or their parents were related. What kind of testing can they find out about? So there was a lot of interest there, and I think young people are quite good at taking this information on board. There was a lot of banter as well. You know, some of the boys were like, "Have you seen my cousin? Do you really want to get married to my cousin?" So it's all those types of things that you get, which is really nice, because I know people worry about this information, you know, being shared with young people. And I'm a mother, so the first thing I want is safeguarding. So I always let them know who they can go to for support within their school, because you know there's this kind of an issue people won't want to talk about around their peers, but they need to be able to find that person that they can talk to in confidence. So safeguarding is really important. And I know there was a lot of issues with me sharing my story. There's quite a lot of suspicion raised about it. Again, people are really suspicious and fearful of you talking about these things openly, even in education and healthcare. But the package that we were doing in Birmingham was kind of then tucked into something called the Best Start in Life. So preparing, thinking about your future and when you have a baby and the kind of things that you need to think about, and genetics is one part of that. So that worked really well.
Thank you. It's about giving permission, I suppose, isn't it, for people to talk about their experience. Charlotte, do you want to pick
Thank
that up?
you so much, Sadia. I have no idea how much your ears burn, because I don't think I go on any meetings without talking about you and the amazing commitment that you have to actually spreading your message and wanting to get other people involved with PPI. I'm always really interested, and I think Phil and I might have had a discussion about this as we're leading on EDI, is this thing that we seem to have in Britain, that it's only Pakistani Muslims that marry their cousins. Well, I mean, I'm a bit boring. I did English literature at university. Don't ask me how I got here. So PPI, just so you know, is patient, God, why is my brain just gone? Patient participation and involvement. Sorry, just saw Seema just put a message in there, just so you know. I was reading through some Jane Austens, and the number of those where people marry their cousins or are expected to marry their first cousins, and it's all completely acceptable. So actually, this is something that has only recently come about, that people even comment on it. It is still a practice amongst a lot of other groups. And I think that it's so tough that the only focus then becomes the Muslim community. It is happening in a lot of places. It happens quite a lot in rural communities as well. I think the Gypsy Roma traveller community as well go through this. So I do think that there's a lot of education that is needed for the health professionals about taking the focus off and saying it is only one community. because it is many. And I think that what you're doing is amazing, because you're kind of going beyond that. Actually, you know what, it isn't just my community, there are others as well, but you're running with it and you're talking about it to people. I think it's really important that we get more patients involved with talking about their own experiences. So it's great to have had you here, and I know you've been having a bit of a rough time recently with all the things that have been going on. So desperately, I'm so grateful to you for coming. I suspect Phil and I might well be approaching you at some point to come with us to, if you can, join us on some of our little roundtable expeditions. So thank you very much.
Thank you. Not a problem. Happy to do that.
Thank you. I think Karen's got a question. Oh, you're on mute, Karen.
Someone had to do it. There we go. Thank you, Sadia. That was a really powerful story. It's interesting. I've been doing some work with the culturally sensitive service in Birmingham with the maternity teams there and the close relative marriage midwife. But this is the first time I've actually heard someone's story and experience. And it's really important that we hear that, because that's, you know, it makes it so real, doesn't it? And it's really just a comment just for people on the call, or just some information, is that there are some modules on e-learning for health, exploring close relative marriage, and there's one specifically for midwives and one for health visitors, and one just in general looking at some of the cultural sort of aspects. I personally found them quite helpful. I don't know if you've looked at them, Sadia, but I will put the link in the chat, because I think, you know, all health professionals should be aware, especially midwives and health visitors and people working with families. So I'll pop those in the chat in a minute. And thank you again.
Thank you.
How are your family adapting, Sadia, now that you're obviously becoming a resource for quite a lot of families and people?
I'm constantly nagging my sister to get involved, and I understand, because obviously she's had 5 losses and it's difficult to talk about, but even my research is like that informal kind of steering committee. It guides me on everything that I do, and she's probably sick and tired of me talking about it. But it's, you know, I always say your story is so powerful, and her husband, I think he's warming to the idea, and it's important to have a male voice. It'd be interesting to hear. He is warming to the idea, but a little bit more work I need to do on that front. But you know, they're just constantly hearing about this, and something that my mum always says to me, that you know, don't talk too much, you might get into trouble. But I feel like I'm kind of past that now.
Oh, well, we wouldn't agree with that, would we? We think the more we hear, which is really what today is about, the more we hear from the patients and the families, their experience of genomic medicine, the better hopefully we can make it in the future, because it's very early days, isn't it?
It is.
As I think your story is
And I just
illustrated.
I just wanted to make a point that it's really important for everyone to listen. So just because you look like me doesn't mean that you know that gives you a pass not to listen. Interestingly, those researchers and healthcare professionals who are from like the Pakistani background have been the ones who have been most fearful of what it is that I talk about, and the most, you know, they don't trust me. I was even told by a researcher to avoid this topic because it's too political. And so that makes me think why people are so, maybe because I'm a patient and with lived experience, I'm not scared of talking about this topic, but other people are if they don't have that experience. But I found that really strange that, you know, they've been the least supportive. And I probably think that comes from some, you know, a place of fear.
Yeah, definitely. I think Phil's got a question there.
Yeah, I don't have a question. I just wanted to say thank you so much, and really, and just to repeat what everybody's saying, your story, patient's voice, it is so important. It is so impactful. And when we're thinking as healthcare professionals on how we are looking after our patients, how we're talking to patients about what is confusing, genomics is confusing. It's just having that understanding and knowing that you've listened to somebody. It just gives you I think a different view. It's not just about the form in front of you, it's about the person in front of you. So thank you so much.
Thank you. No, I agree with that. Thank you very much.
And I think also you've illustrated a lot of what we've been talking about this morning. I mean, we had Beline talking earlier about conscious and unconscious bias, which we carry with us without even realizing, you know. And I think having your story really gives sort of weight to that, doesn't it? And an understanding of how we need to be careful about the way that we think. So thank you. Any other questions coming in? Let's have a little look. Anything in the chat? Thanks, Karen. No, well, we could maybe think about moving on to the next speaker. That was lovely. Thank you. We're really pleased that you came and spoke to us. Hi, Jo.
Hi.
I think Karen's going to give you a
Jo.
brief intro, if that's okay.
So last but not least, we're really grateful to have you here, Jo. Thank you for giving up your time today. And Jo's also a member of our Central and South GMSA Patient and Public Involvement Panel. So Jo, I know you're going to talk about your family experience of a genomics journey. So I'm going to hand over to you. Do you want us to do your slides, or are you going to share your screen? Yeah. Lovely. Yeah. Thank you.
Thank you. I've got a lot of amazing talks to follow, so I'm feeling slightly nervous, but let's go for it. So I'm going to talk about my family's experience of whole genome sequencing, and it's based around my daughter, who has drawn some nice pictures for you here, so that you can get a little idea of her and what she's like. As she's getting older, she's 10 now, I'm more conscious about what I share about her, and especially with things like this that are recorded, and maybe, you know, on YouTube for a long time. It's sort of, I'm having to think about, how do I share our story, share information without giving away more information than anybody needs, or things that might be detrimental to her in the future. So she's asked me not to use her name. That if I manage that, I'll be really surprised. I'm sure it'll come out at some point. So she's drawn these pictures of herself when she was little, when her difficulties first became apparent, and as she is now as a 10-year-old. And this is sort of to show that we're on a bit of a journey. I was really kind of relieved with Annika's presentation earlier, because I thought that was quite balanced, and she gave a much more realistic view of what genomics can and can't do for families than maybe I've heard in other settings, you know, conferences and things, where it's all like genomics is wonderful and we're going and let's go, and it is great, but there are lots of little stories that are there that are important, but aren't, you know, your kind of flagship end of part one story that sends everyone out on a high. But saying that, as Annika said, uncertainty isn't failure, so we are still undiagnosed, but that doesn't mean that the system's failed us. We're just continuing on this journey, and things like this are important, and contact with genetic services, genomic services, and being involved in PPI is important, because you need, especially when you don't have a diagnosis, you need to be able to validate your experiences and be heard and be in environments where you are understood, because having an undiagnosed condition, you're often in circumstances where you're not understood. So, which hopefully will become apparent through the presentation. So some of my slides are slides that I've used when I've taught for SWAN UK, which is Syndromes Without a Name, which is a support network run by Genetic Alliance for families with children with undiagnosed genetic conditions. So rather than getting a mess with it, I've just used SWAN UK slides for the information that they provide. So some of the slides are mine, some of them are SWAN UK. So if I could have my next slide, please. So this is one of the sort of infographics that Genetic Alliance have put out this year. So they say every year around 6,000 children in the UK are born with a genetic condition so rare it doesn't have a name. That 6,000 children number has been knocking around for a long time, so it may or may not be accurate. I don't know. That's the information we have, and I think that's part of the deal with undiagnosed, is that maybe, you know, there's not someone researching undiagnosed, so the data isn't always that easy to get hold of. So there we go. Well, so 6,000 children a year are born with a genetic condition so rare it doesn't have a name. So if we go to the next slide, I'll explain a bit more what that means. Well, seem to have lost a bit of lost my headings when I've sent it over. So that should say, how could an undiagnosed genetic condition present? Got lost. There's lots of different ways that children with an undiagnosed genetic condition appear. So all of the things listed there, they might have global developmental delay, learning difficulties, communication difficulties, epilepsy, neurological problems, problems with muscle tone, problem with joints, feeding difficulties, dysmorphic, which isn't the nicest word in the world, or unusual features, respiratory problems. So all of these things are, the child is going to present with these at some point in time and begin their journey into trying to figure out what is going on. Sometimes these things are present at birth. I don't know who's on this call, whether I'm teaching you to suck eggs, but anyway, so some things are present at birth, some things will become apparent later on. Sometimes things are discovered before children are born, sometimes it's after they're, after they're born. What we find with undiagnosed family is that we've all got different symptoms, because obviously we're all very unique, all different symptoms, different presentations, but very much common experiences. It's probably worth saying at this point that before I had my daughter, my background was learning disability. So I'd worked with children with learning disabilities since sort of college, and then I'd become a teacher, and I taught in a school for children with complex disability. So I was very aware of learning difficulties. I was very aware of genetic conditions and that they could be undiagnosed. So that wasn't a shock, but it doesn't actually make a lot of difference when you find yourself in that situation. So if I have the next slide, please. Got my title on that one, that's good. So there are some main reasons why some conditions are really hard to diagnose. So they're the rarest of the rare. There's something that has never been seen before. They can be an unusual presentation of a known condition. So it might be that it's appearing in a boy when it usually appears in girls, or it could be that there's a list of symptoms and sometimes, and you'd expect to tick off 3 or 4 of that list, but that child's got all of them, or a variant of unknown significance, which is where a lot of us have come to through whole genome sequencing. So where the clinicians find a change, but you don't know whether it's significant or not, and it can take an awful lot of working out to find that. So historically, it's been research studies that have helped find answers for children who have conditions that are hard to diagnose. So the DDD study, and then 100,000 Genomes Project, and then obviously that's all gone mainstream, as you know. We go on to the next slide. I will tell you a little bit about my experiences. So I had my daughter in 2013, and it's a bit of a weird one because I didn't really have any kind of hard evidence that there was something wrong until after she was 1 year old, but I always had a niggle. And partly that was because, like, when she was a newborn and a young baby, she'd feed and she'd sleep, and there wasn't much alert time. And she was my first baby, so I didn't have anyone else to compare it with, so it is a little bit harder then. And then when she was kind of getting to the milestones, there were just little things that happened that she took a little bit longer to get there, but it wasn't things that anybody would would worry about your health and worry about it. And now I can look back and find things like she did the rolling over at 3 months old, but then she didn't do it again for a long time. So then what happened was once she got to a year old, and she'd started babbling and she started walking, and she started, you know, she'd do a little action songs, wind the bobbin up and everything. And then that stopped. And so she wasn't babbling anymore. There was no attempt at communication. And she was very kind of withdrawn, and she'd go off and play with her toys, do whatever she did with her toys, but she wasn't really paying much attention to me. And like, you know, she'd go running down the living room and kind of veer off to one side. And it took a long time then, well, relatively long time, for me to know what to do about that and who to talk to, because you'd have those kind of initial, oh, it's fine, she'll catch that, oh, she's not behind, she's just, you know, she's doing great. And she's had problems with allergies, so I kind of got into, she'd seen a consultant for allergies and that kind of thing. But even then it was, you know, when you first go to the doctor and you're like, I've just started weaning my child, and you know, I think it's that bit of a rash around her face, and I think she's actually still being sick, and other children her age aren't. And nobody's when you walk into a surgery like that, nobody's thinking, oh well, this must be a rare condition, let's you know, let's send her off to the pediatrician. It's just not the way it works. But you know that these things aren't right, and it's a case of getting the right person, really. And what happened was that I took Megan to see, I've done it now. I took my daughter to the doctors because she had molluscum, I think it was. I didn't know what it was, and saw this GP I hadn't seen before, and I just liked his approach. I liked the way he talked to me, he listened to me, and I thought, right, I'm going to go back and I'm going to tell him all these other worries that I've got. And so I did, and he kind of said, well, can be normal, and I said, no, it's not. Okay. Just no, it's not. So he referred us to pediatrician at the hospital, and it kind of went from there, really. So you kind of going from being the, oh, am I just an anxious mum, I'm being told I'm an anxious mum, to right, you're in hospital and the tests are starting, and kind of off you go. So what happened was that we went into hospital, got called into the children's assessment unit rather than an appointment, which was a bit scary. And then they sort of went in one day, and then they said, I'll come back tomorrow, we'll do some tests and see a neurologist. So it was like that day of being in hospital, I can remember that more clearly than probably any other memory I've got, because it was just such a shock to the system. And then they started genetic blood tests, and I saw the neurologist, and he started talking about things which it turned out weren't the case, that kind of conditions that will lead to quite profound disability, which my daughter doesn't have, as it turns out. So things like Rett syndrome and Angelman syndrome, so things that are rare conditions, but are, you know, there's known tests for them. And then she also had kind of booked in to have an EEG as well. So she had all these blood tests for genetic conditions, you know, and then we went back a couple of weeks later and she had an EEG, and then also she had to have an MRI and a lumbar puncture. So you've literally gone from, oh, you're a bit of an anxious mum, to bam, everything. And then, as Sadia was saying earlier, and this, you just end up waiting. You just end up in this kind of waiting phase where you're waiting for results, but you don't necessarily know that. You learn these things over time, that actually NHS systems fail quite a lot, and any emails don't get to places and appointments don't get booked, and actually you end up having to chase things. So I was then with a child who I didn't know what was happening to her, because she was like, this is what she'd done all the time. She kind of make a little bit of progress, go back, a little bit of progress, go back. She wasn't communicating, she wasn't talking. When I took her out, she was just sort of like wandering around and picking stuff up, pick up leaves and twigs. And that child now, compared to the child I've got now, is completely different. So if we go to the next slide, I was then just highly anxious because all these tests had happened and I had no results. It turned out there had been a bit of an issue with booking the follow-up appointment, and it hadn't been booked, so that took a bit of chasing. And also, while this was going on, I was also pregnant and had another baby while I was waiting for all these tests to come through. So I spent a lot of time wandering around, pushing a pushchair, thinking, what am I going to do? What am I going to do? I don't know what to do. How am I going to, what's going on? How am I going to get the answers? Why can't I get in touch with the hospital? How am I going to get the support she needs? Where's she going to go to nursery? Just absolutely consumed the whole time. And at the time I lived in a flat, I lived in the second floor flat, and the post box was downstairs. So I'd see the postie come and put the post, he may have given me post, and I was stuck upstairs with two babies. I couldn't just kind of go and check the post, and every day I was thinking, is it going to be an appointment? Is it going to be results? And you're just stuck in that place. And then I needed to sort of get her into nursery and start to see what other support we could get in place. Obviously she's not communicating well, she's not using her hands that well. So it's an awful lot that's going on in your head. It's taken some therapy to get to unravel it all, and just to acknowledge that what you've been through was really traumatic and really difficult. When you start to access services like speech therapy, occupational therapy, the understanding in those kind of NHS areas about rare disease and genetics isn't great. So I would finally get the appointment, and then I'd be told, well, she's not that far behind, or whereas what they weren't acknowledging was the regression, and the neurologist involved and all the genetic testings that were going on. So it was kind of covered earlier in Annika's presentation. I kind of noted it down. So one good thing about going last is that when you're trying to access community services, you are reliant on that healthcare professionals' knowledge of genetics and genomics and rare disease. And if it isn't that much, because that's not the area they work in, then it is harder for you to communicate that. And this sort of genomics education across the wider NHS, it's not just about getting people to understand the clinical side of it. It's getting people to understand the impact on patients and what they're experiencing as well. So if you put to my next slide, so I've got a cartoon that isn't as impressive as some of the ones we've seen today. So this is a cartoon that I drew as part of a project I'll talk a little bit more about later, which is the Ethical Preparedness in Genomic Medicine study, funded by the Wellcome Trust. Probably better say that at this time. So one of the things we've looked at is graphic medicine, and so myself and several other parents of children with rare conditions took part in this, where we use different creative methods to kind of explain what our experiences were. So this is one that I did that kind of showed my experience, where you're waiting, you get that relief finally. I've got my appointment, we're going to see the speech therapist, I'm going to get some help. And then they say, well, what a lovely little girl, she's no trouble, because my daughter is quiet and compliant as part of her condition as it is. But you know, and then you get told they're fine, and you know, you've got nothing to worry about, mum, because you always get called mum. But it leaves you then, right, you haven't been heard, you haven't been understood, and you haven't got the help. And I had to fight like mad sometimes. Yeah, I've sat in a meeting and told the occupational therapist I wasn't leave. That meeting wasn't ended until she booked appointment to see my daughter. It's just, and it was needed, you know. I wasn't just being awkward, but you know, when you're advocating for a child, you probably, you know, for yourself, you would give up a lot more easily. But you know, it's somebody that can't advocate for themselves, so you have to do that. So what happened with all those genetic tests eventually came back fine. The MRI was fine, the EEG was fine, everything's fine. Like two things there. One, the NHS is not good at telling you if a result is normal. But actually it's quite important if, you know, I think people think, well, if your result's normal, that's good news, but actually it's not always good news. If it's not giving you an answer, you still know that there's something wrong, so it's not best. And then I forgot what I was going to say, so I'll just so all our results came back normal. We then went to we got referred to another neurologist at another hospital for kind of a tertiary referral. He thought maybe the condition was Landau-Kleffner syndrome, because that's a condition where people have seizures in their sleep, and that affects the communication. So we had EEGs for that, and they were all normal. So at that point, both neurologists said, well, there's this 100,000 genomes project, so we'll put you forward to that. And obviously we're going back to early days of genomics and genome sequencing. So, you know, we were told that it was it's going to take a long time, but it's getting faster. And you know, as was mentioned earlier, it was initially sold as being a little bit more conclusive than it turned out to be. So I'm just looking at my notes. Yeah, so if we go on to the next slide. So we went for the whole genome sequencing, and that is a long wait. That was a long wait. We'd had our first genetic tests in July 2015. We then saw genetics in October 2016, and we enrolled in 100,000 genomes in January 2017. And yeah, we were kind of told it's always the library and the books, and I think we need to move on a little bit from libraries and books. So it's a good starting point, but we need some better ways of explaining genomics and genome sequencing from that. So we were told, well, you know, before for a genetic test, we could just look at one book, and now we're going to look at the whole library, which isn't the case at all. Yes, but we were kind of given the impression that if there's something, we'll find it. I mean, one of probably the positives of it taking so long is that by the time as time went on, it became clearer that actually, no, you're not going to necessarily get a result, and they're only looking at panels. But I think that's where sort of organisations like Swan UK and the other parent reps that were involved in different things, like the patient participation panel for 100,000 genomes, and they were getting more information at that, and they could share back down, and you know, it was we were kind of getting a better understanding of what this was what was going on. And of course, while I'm waiting for all these results to come through, I'm still trying to get the support of the speech therapist and the physiotherapist and everything else, and it's all going on. There's an awful lot going on. I must say that my health visitor at that time was just amazing. So hopefully there's some health visitors on this training, because it's sort of aimed at them. But they do play such an important role in supporting families at that kind of time. And what I found she was ever so good at was sitting in these kind of multi team ear, and actually hearing what everyone was saying, and being able to support me by saying, well, actually you've said that and you've said that, but do you not think this? She was brilliant. Sadly, there isn't anything beyond that, so I don't have anybody who can support me in that way since we've been into school, someone that's got that kind of clinical knowledge. But yeah, shout out for health visitors, because they are invaluable to families when they're going through these kind of things. So if we go to the next slide. So this is looking at coordination of care. So Genetic Alliance has done some research into coordination of care called the Concord study, in sort of coordination of care for people affected by rare disease. It's not generally well coordinated in the UK. Limited access to care coordinators, specialist centres and care plans, and this lack of coordination results in delays and barriers to accessing care, significant burden on patients and carers, and negative impacts on patient and carers' physical and mental health and their financial well-being, which I can completely identify with. So I've just put up some of the different clinical departments and specialists that we've had involved over the last 9 years. A lot. It's a lot to manage, because as a parent you're managing that. There's no lead clinician, there's nobody sorting that for you. You're reliant on giving the information from one person to the other person, and kind of making sure that everybody's there. And then you can find, with that many people involved, that if you do have a problem, I just like in the middle, who's going to help me with this? And you go to your GP and they say, well, actually you need to go to the community paediatrician, but you haven't got a community paediatrician appointment for 6 months, and you do spend a lot of time just there, just waiting for things to happen. And I had the experience just yesterday where we'd been on a 9-month waiting list. We got to the top of the waiting list and they said, actually, no, we're not going to help you. You've had this service before and it didn't work, so we're not going to see you. So I've just wasted the best part of a year on a waiting list for a service I was never going to have. And now, right, who do I talk to? Who's going to help me now? They say go back to your GP, or do I go to this clinician, that clinician? It's really tricky. I've kind of learned to, when it gets that overwhelming, I don't carry it all with me anymore. It's kind of that more healthy, like feel it all and then kind of move on, really. But yeah, a lot of interventions. If you look at ultrasound, lumbar puncture, MRI, EEG, sleep study not, but the rest of them, they've all been normal. So yeah, it's hard to know whether they worth doing or not. I don't know. You always hope that something's going to give you an answer, and then it doesn't. Okay, we go to the next slide. So our 100,000 genomes project results eventually came back. It was just at the start of the pandemic, so it was when everything had gone kind of like telephone appointments, but nobody was quite sure how long it was going to last, so we were a little bit more hopeful that it was going to be over quickly. And then obviously we know the history. So it just happened that I had a phone call with one of the neurologists, a planned appointment, and he said, "Oh yeah, I can see on here your 100,000 genomes project results are back," and yeah, they were normal. And you know, after spending 3.5 years stalking the postman, it's not, you know, it's a bit. One of the issues with 100,000 genomes was there was no kind of thought about how results were going to be given. So lots of people have had results in lots of different ways that weren't necessarily the best way of hearing things. And as I sort of said before, sometimes being told that there's no result isn't actually positive or doesn't feel positive. And then we kind of got the follow-up letter a couple of weeks later that then actually did come from clinical genetics, which told us that there was a variant of uncertain significance, and another study that we could go into called splicing and disease, which was looking at RNA, and that's as much as I understand about that. However much I've tried to, I can't understand what that means. That study had been put on hold for the pandemic, so it was a little while before we got into that. It surprised me when I was looking at this slide that actually now it's longer since we had the results back than it was that we were waiting for them. I don't know where those 4 years have gone. So yeah, we got this like variant of uncertain significance, and then that went off. We went off, had another blood test, had the splicing and disease study, and then we've had once the results were back, we saw the geneticist again, and kind of back to the books and sentences and everything. So they found more information about this variant of unknown uncertain significance. And the difference was that the change on my daughter's gene was different from what had been seen before. So usually there's a change, you know, in that string, it's like having a letter change or missing, whereas in my daughter's case, there's a whole string of words missing. And that's not been seen or recorded anywhere. So it's recorded as a variant of unknown significance. And then the geneticist looking after my daughter has registered an interest in that worldwide. So there's a couple of things going on there. There are clinical studies going on into that gene in Cambridge for a different reason, for obesity, because that's another thing that's known for that gene. So he's asked them to run it and see if they can find more evidence. But that's a few years ago he's asked, and they've not been able to do it yet because science and technology, science and technology. And the other thing is that in Germany there's a study going on where they're collecting lots of data about patients with changes in this gene. So her information's been put into that. So it's almost like we found the gene change, but we can't prove that it is that. So it's like backwards. It's rather than having a hunch and then doing the test and confirming it with the gene, you've got the gene, and now you've got to kind of find the evidence to work out to prove it's right. I really want that result. That result is really important to me. Because I have been through so much and had my experiences not understood and not validated so much, that you question yourself and your sanity all the time, that I would love that for me. Maybe it's a bit selfish to know, yeah, that was it, it's that gene, and this is what this change is doing, and that would explain things. Because the way that she is, I mean, she had all those really looked like she was going to have really profound disabilities from the way that she went, but actually over time she's picked up. And although she's got some sort of significant communication difficulties and a few other things going on, with support she's fine at mainstream school and she can access the work. So she's doing really well. She loves her art. She's really funny. It's important to her as well to understand herself and for people to understand that she's got these difficulties. She thinks it's great. She's like, she says to her little sister, well, I'm important because I've got all these scientists trying to work out what's going on with me. She thinks it's wonderful. As part of this, she has got an autism diagnosis, and that helps her because it gives her an identity. The children have so much more access to information these days, and she watches cartoons that people have made about their experiences of autism, and it gives her an identity, and it gives her a way of explaining her communication difficulties, and that's important to her. And kind of having that diagnosis, it is a bit of a double-edged sword because it's important to her. I'm happy for her to have it, but I think sometimes, and it also kind of makes it obvious to people that there are difficulties, who, rather than saying, oh, well, she's got a variant of unknown significance on this gene, because that won't mean anything to anyone. But then it can mean that sometimes people make assumptions about her that aren't true, because she's not classically autistic. She's not bothered by loud noises. She's not sensory sensitive. And sometimes people can say, oh, well, she's done that because of that autistic trait. And it's like, well, no, she doesn't have that autistic trait. There's different reasons. So the diagnostic overshadowing can happen in different ways, I think. So if I'll move on to the next slide and talk a little bit more about the importance of understanding lived experience. So I've got a few different images going on here. So I mentioned earlier the research with EpiGen project, ethical preparedness in genomic medicine. That's happening at Brighton and Sussex Medical School and funded by the Wellcome Trust. So several of my lovely friends who have children with ultra rare or undiagnosed conditions and have all been through 100,000 Genomes project. We've done quite a few little projects. We've done writing, we've done collage, we've done poetry, animation, graphic medicine, all as sort of different ways to explain and help to understand the experience of having a child with a rare genetic condition. The two photos in the bottom left, it's the lady in green is Gillian Hastings-Ward, who is the chair, or currently the chair of the patient participation panel for 100,000 Genomes. She's about to step down from that role. And Dr. Rich Gorman, who's one of the researchers on the EpiGen project. The other one is Professor Bobby Farsides. Then that's me and Gillian at the Genomics Summit at the Oval last December. So PPI sort of gives the opportunity to kind of go and be part of these events that most people are, even those working in the field don't get the opportunity to. So that is amazing, and it does make a difference. So one of the outcomes of our project was a book of poetry called Helix of Love. I've got links to it at the end. And the photo below it is a photo of Professor Dame Sue Hill talking about it at summit last year, an international summit on genomics education. So through Gillian's contact, she's done really well at kind of spreading awareness of our book, Helix of Love. And at that conference, Professor Dame Sue Hill used our example of the work that we'd done and how important it was to hear patient voice. Every delegate went home with a copy of the book to wherever they were in the world. So, it's a real example that patient voice can be really far-reaching and kind of done in creative ways. I think going back to the first presentation this morning, and how you kind of break down barriers between different cultures. And I think art and creativity are a really good way to do that, and probably need to be explored more. And then also one of the things that was discussed in that was kind of the patient's view of clinicians as well. I think you can use that kind of art to break down that as well. So whereas most of the projects we did were with artists, the one that we did on graphic medicine was with Dr. Muna Al-Jawad, who works at Brighton and Sussex Medical School and is a consultant geriatrician, but also has an interest in graphics medicine, kind of so led that section for us. And it was very much, you know, she learned from us. And she said, you know, that will impact the way that I speak to patients and I deal with patients. But you also saw some of the things we drew, and you know, and we ended up having discussions about how, you know, we all, well, no matter what we're doing, we've all got to go through that thing every evening of what we're going to give the kids for tea, and you know, we all got to do the washing and find the lost sock and that we forgot to put in, and you know, you can find those human things that you've got in common. And I think especially when you're seeing clinicians over a long period of time, there's a way of giving a little bit of yourself to that patient without, you know, not over familiar at all, but just that little connection. So you know, I think it makes a difference to kind of see each other's human side. And also there's also ways that this PPI can be done really badly. So I've attended a couple of online events recently which were designed to get patient feedback, but it's for a group of people and they've got an agenda to get through in an hour, and you don't actually have time for everybody to say anything. And some people are there have gone with a different agenda, and they you know, I've got this person and I really need to say my story because I'm having this really bad time, which is valid, but not the right place, but probably the only place. So there's ways of doing it badly as well as ways of doing it really well, I think. If we go on to the next slide. So this is a bit of random poetry. So at the beginning of January, I'd had 2 appointments. One was genetics with a kind of update on, yes, these things are still going on, but I haven't heard back from anyone yet. We still have a genetics appointment every 12 months, which is really reassuring. And then I've seen a new neurologist because the previous one had retired from doing outpatient work. So I had to explain the story over again. And I think it's much more difficult to understand my daughter now if you haven't seen what she was like when she was 3, 4, 5, 6, because it was different. And I asked about kind of plans, and she said, well, you know, we've done a lot of tests, and they've all been normal. So I think probably our involvement's coming to an end. And I found that really, really difficult because I don't want to be left. The thing, you know, if you end up left with you've not got any appointments anymore, and you've not got a diagnosis, you haven't got anything. So that felt quite difficult in those few days. And then this poem, this is like an extract of this poem, and it was Joe Trissini, who he was in a pantomime. He'd written the pantomime. He was a good fairy, and he had this poem at the end. And this part, I heard it. It was like, you know, shared on Instagram, and I heard it, and then I was sat in the car park and I was listening to it several times. And this bit about hope. Hope is more than wishful thinking, but it's less than certain sight. Hope is knowing behind darkness, life is always hiding light. Hope is never a decision. You don't choose the hope you lose. But if you're here, you're never hopeless, because hope beats the hearts we use. And I feel like genomics is that. Genomics is the hope. genomics is definitely more than wishful thinking and less than certain sight. But if you've got that and you know that there are people that believe in you and your child, and there's people that believe that what is happening to your child matters, and even though it's a very individual experience, you know, it's important that it's understood and she's supported, you know. And you have these kind of experiences all the time, you know. I found, you know, you hope that the speech therapist is going to help you and then they don't, or you go to a new clinician and they don't quite get it. So, you know, you don't choose the hope you lose, but you don't lose the hope, you know. You just have to kind of find other ways forward. So that has really stuck with me. And I thought it was important to put that in there, that whether or not you'd get a result from it, it gives hope that you wouldn't have otherwise. I don't, you know, if this was 10, 20 years ago, I don't know what situation we would be in, but it would be a lot worse. We'd be worse off, but without having that hope. Okay, and then if we just go to the last slide. So that's just some links for further information. So Genetic Alliance and Swan UK, Medics for Rare Diseases are a really good source. One that I've recently learned about, a global nursing network for rare diseases, that website's really worth looking at. And then our EpiGen project. So there's a link to information about the project and the poetry book. And then Rare Minds is also a brilliant resource for people. They provide counselling for people who have rare conditions and their families. The Brighton and Sussex Medical School are tweeting some readings of the poems. So if you go onto their Twitter feed today, or X, or whatever it's supposed to be called now, yeah, you'll see some of the participants reading their poems, which is really powerful, especially, well, they're all amazing, but yeah, especially Alex's in particular. But yeah, definitely worth a look if you have time. So thank you for listening.
Thank you so much, Jo. That was great. It's so kind of you to come and share such a personal story. And I've made lots of notes. But I think the thing that I've got two things to say really before I see if anybody else has any questions, is it's lovely to hear that your daughter is making sense of her world in the way that you've described it. And also I think there's a real lesson in what you're saying for all healthcare professionals, regardless of background, regardless of specialism, in that when we meet an individual, we don't just meet them, do we? We're connected into their family and their friends, and that we need to listen attentively, and we need to be aware of we need to be genomics aware, basically, don't we, and be able to respond appropriately. So thank you very much. And I think we've got a hand up. Who's that? That's Phil. Phil would like to say something.
Hi, Jo. Thank you so much. Hello. Very powerful story, very impactful. And I'm just going to say about the Helix of Love poetry book. For me, it's just totally blew my mind, because poetry is not my thing. However, reading the poems just like really brought it really to life, essentially, about thinking about the impact that you potentially have when you're speaking to families, and thinking about the experiences they had, and how you can, I don't know, target or tailor the way you're approaching patients, which sometimes is difficult because there are pressures in the NHS, but it's really important. So I really would urge everybody, if you have a chance, please go through that book. It is beautiful. It is sad. It is just so powerful. But I think one of my main question for you is, well, I suppose there's two parts of it, is that you haven't got a diagnosis. So not having that diagnosis, I think it'd be really, you said it already, but it's just thinking about the support after not having a diagnosis. Not, you know, you've got a result in front of you, but it's not a diagnosis. And so how difficult is it then to get further support with not having a diagnosis? Am I making sense?
Yeah. I think when we're still very much kind of in the sort of clinical side of it, so genetics are still supporting and neurology is still there for now, and that's always been the easy bit, because they understand that's what they do all day every day. You know, they understand rare disease. It's when you take it outside of that and you've got to go and get support, education support, or that kind of thing, it is very difficult. And it part of it is because they want evidence, and they want, you know, and you haven't got that evidence, and you can only give them a clinic letter, and the clinic letter, you know, isn't written for them, so it's not necessarily going to give the information. And there's also not that understanding that actually it's the parent who's been to every single appointment that has the best knowledge of that what's going on for that child. They want the evidence all the time, so that's quite difficult. And then if you kind of have new people come along, you have to start all over again and try. It's if you had a starting point of people understanding what rare conditions were and what genomics was, it would help a bit. But yeah, not having the answers and the evidence. And it also sort of came a bit with her HCP. When we got the autism diagnosis, the caseworker sort of decided, oh well, there's an autism diagnosis now. She started crossing off all the other bits that as though they didn't matter anymore. And I had a bit of a battle on my hands saying, no, it's not. And then you have to get the evidence for them. It's just, you know, send them a genetics letter that they don't really understand anyway, but they feel better because they've got it.
So taking that into consideration, then how do you think for us healthcare professionals, how we can support that process a bit more?
I think it's the information that you get to take away with you, but it's really hard because everyone's time pressed, and you know, no one needs to get bogged down in paperwork. I think there's more work to do with education in general, and the, you know, teacher training and awareness of rare conditions. Something I've kind of tried to do a bit myself, but been a bit on my own with. But if anybody else wants to work on it, I'm more than happy to put the effort in and do some training for schools or information for schools.
Well, you may regret saying that out loud.
No, I won't.
Thank you so much, Jo.
That's not the thing to say to my team, because we'll all just go, yes. So we will work with you on that, Jo. Thank you very much for your story, Jo. I think the things that stood out for me were, as others have said, that it isn't just about your child, whose name we don't know because you never said it. But it's also what happens to you and the rest of any families, and what support there actually is for those family members, the parents, brothers, sisters, whatever, who are also affected by a non-diagnosis, but something which is wrong. You know, I think that for me was something that stood out, that the focus is very much a lot of the time on the patient. And I think you and I have had this discussion before, that you've gone, and instead of being the parent, you have become the educator and talking to them about what the problem is and what's happened, and let me explain all this. So it takes away the bit where actually you're the vulnerable person who needs some support from them. You stop being just like any other parent, any other mother. You become the educator. And I think it's really important that that's something that we also realise in the work that we're doing, that we start to look at how we can help with that kind of thing. And I notice that Beatrice has actually said, have you received any kind of counselling at all? I think you said you had some support with that.
Well, through through Swan UK, they had some funding for Rare Minds a few years back. That part of the issue is funding, and Genetic Alliance Swan UK, they don't get a lot of funding, so what they can do varies. But anyway, they had this funding for Rare Minds, and so myself and 3 or 4 other ladies who are parent reps, we did some group therapy for about 6 weeks, I think, and that had a lot of benefits. Before that, I couldn't see what I'd been through and how much what I'd been through was affecting me. You just kind of just put it all on yourself and think it's you. And also that acknowledgement that what you're going through is traumatic, which you don't acknowledge at the time, and isn't very that well acknowledged anyway, that parents going through these things, it's traumatic, and you are on high anxiety and high alert a lot of the time. And then that had 2 benefits. One, I'm a lot closer with those ladies now, and I've got a really nice support network with those, and we've got our WhatsApp group keeps going, and we're you've got someone you can shout to if things get a bit too much. The other thing is, it made me kind of realise the benefit of having therapy, and that there were things that I needed to explore. So then I found, I've sort of self-funded, for want of a better words, and about 1.5 years of weekly conversations to go through that, and other aspects of your life, as therapy tends to do. But it's helped me. But yeah, that kind of mental health support isn't there, and it's a massive change as a parent to have a child that is with additional needs, and then when you haven't got an answer either, you haven't got a support network, for things like Down syndrome, Rett syndrome, they've got a group of parents who've been there and know what it's like. And whereas I could Google my daughter's symptoms and genetic change forever, I would never find anyone who's on answer or anything the same. I've tried, I know. But also it's changed my life. I was a teacher, and then I didn't go back to teaching because you can't be a teacher and have to go to 1 million appointments a week. It just life doesn't work that way. And then time had gone so past that I didn't want to go back into it, because I wouldn't have gone back as good as I was when I left. And then I did do a couple of years. I worked as a care coordinator, as it was for a GP surgery, learned disability care coordinator. There I learned that you can't coordinate care without clinical input, and that is important when you're thinking about coordination of care. But then there was a lot of changes at school, and my daughter wasn't coping, and she wasn't want to go to school, and I had to stop that to support her, and I haven't gone back into work again, which is why things like this are great, because I get to do PPI and go to different events and actually engage my brain and think about things, because it massively changes what your ability to be who you were before.
It seems to change identities. It's like a lot of other things, it changes. I mean, you've got that thing anyway that a lot of parents, and I'm sure there are parents on here who will say, you stop being yourself, you become mum or dad, and you don't actually have an identity. But when you can't even have an identity outside of the home, then that must be very hard. But we are so grateful for you coming and sharing your story. One of the things I would say is you said very nervous when you started and felt you were going after a lot of brilliant people. I would suggest that you are one of the brilliant people. So never ever be worried, and we will definitely be getting you to come and talk again, and probably do some work with us as well.
Yeah, that would be great.
Thank you so much, Jo. I echo that. I'm sure we all do. We're really pleased that you came and made the time today. So thank you.
And my daughter's really pleased that I get to share her story as well. She's really involved in. I tell her what I'm doing, and she loves the poetry that we've done. She's written her own poetry, and
that's the next book.
Yeah, probably no one had, but you know, getting children to, as you know, at this age and then older, to be able to understand these things and advocate for themselves is really important as well, I think, when you're thinking about it.
So she is right, she's very important.
She's so important. Thank you.
Okay, thank you. Well, I think we're sort of drawing to a close now. We've just got a couple of slides to share. I don't know if Phil can get the first one up. It's just a little bit around genomics training and some signposting. And then we've got, as mentioned earlier, we've got a feedback form that we'd really appreciate people filling in. It'll come up on a slide in any minute now. And will be sent out by email. We'll be sending out the slides and the recording and a certificate. And I forgot to mention at the start, we do actually have RCN accreditation for this webinar, so that will obviously be on the certificate that comes out to you. So I think it's just time to thank everybody for making the time and coming along and interacting, and whether that's in the chat or however you've taken part. So how are those slides going there? Phil, have you got the final ones?
Thanking everybody. I'm on the final one now. But yeah, I hope I hope everybody has managed to get if you haven't been involved in genomics before, it's just about thinking about the patient in front of you, thinking about the conversations you're having with the patients, and thinking, and I think one of the biggest things is for me is when you think genomics, think family. I think that's one important thing as well. But thank you very much to everybody that has joined.
Are we sharing those final slides, or they'll go out anyway when you get your get your email? That'll come around with the slides. You'll be able to see the links at the end of it.
Here you go, Mary. Feedback form slide.
Can't see the slide.
We can't see them.
We've had a malfunction right at the end. Having a malfunction.
Was I not sharing before?
No, you're not sharing.
Was I not sharing before?
There we go.
There we go.
Oh, my goodness.
I realised you thought you were showing it.
Yeah.
That's our feedback form. And like I said, that'll come out on email to everybody who's registered. And I think the slide before that has got some links on genomic training. There you go. So that just goes through the variety. You are now. Thank you. The variety of genomic training that is available. And that's running through, obviously, Health Education England, Genomics Education Programme. There are various MOOCs, FutureLearn, St George's. There's various pharmacogenomics information out there. So lots to look at, and keep an eye on our web page and Twitter feed, and I'm sure we will be doing another webinar in the future. So thank you very much. I think that's a wrap. Does anybody else want to say anything?